Abra madam, hello Bengal sir, hello Archana madam. Okay, we are now streaming live on YouTube. So I would request Dr. Ashna to take it forward. Yeah.
Yes, sir.
Yes.
Thank you so much. So we'll begin in another 2 minutes. And since we've got a large number of participants with us, so we have streamed it live on YouTube as well. And the link will be put in your group so that you can circulate it amongst the participants, and they can also watch it live on YouTube. Also, all the speakers, this is the workshop details, all the sessions. So we have roughly 15 to 20 minutes per speaker, and there'll be an alarm bell at 12 minutes that will remind you all that last 3 minutes are remaining. So we request you to stick to the time limit. We'll just wait for another 2 minutes, 2-3 minutes, and then start.
Dr. Ashna?
Yeah, should we start now, sir?
Yes, I think we can start the proceedings.
Okay. So I welcome all the eminent faculties and the participants for today's workshop on online obstetric skills workshop.
नमोऽस्तुते सरस्वती त्रिशूलचक्रधारिणी सितम्बरावृहे शुभे मृगेन्द्रपीठसंस्थिते त्वमेव विश्वधारिणि त्वमेव विश्वकारिणि त्वमेव सर्वकारिणि
So we have very eminent faculty members present with us today. We have Dr. S. Chabra ma'am, who is Emeritus Professor OBGYN. And we have Dr. Archana Verma. She is Vice President at Foxy, New Delhi. We have Dr. Poonam Verma ma'am. She is Professor and Head at Department of OBGYN, MGIMS, Sevagram. We have Dr. Prabha Ranjan with us. She is Consultant Obs-Gynae at Bhagwan Mahavir Hospital, New Delhi. We have Dr. Anupa Vig ma'am. She is Consultant OBGYN at Piramal Swast, New Delhi. We have Dr. Shuchi Jain with us. She is Professor, Department of OBGYN and MGIMS, Varda. We also have Dr. Nooja Bhalerao ma'am. She is Professor, Department of OBGYN at NTP Salve Medical College, Nagpur. We have Dr. Vidyadhar Bangal sir with us. He is Professor and Head at Department of OBGYN, Pravara Institute of Medical Sciences. And we have Dr. Reshmi CR. She is Additional Professor at Department of OBGYN, Government Medical College at Kerala. And we have Dr. Preeti Priyadashni with us. She is Assistant Professor, Department of OBGYN at AIIMS, Gorakhpur. So we welcome you all. And this is, in brief, the workshop details, that is the various sessions that we have planned for you all. We'll begin with a pre-test, the link for which will be posted in the chat box. And you simply have to click on the link and go ahead with the pre-test. Then we'll start with a welcome note by Dr. Vikram Datta sir. He is President of NQCN. And the workshop will be inaugurated by Dr. S. Chabra ma'am and Dr. Archana Verma ma'am. And then we'll begin with the sessions. The first session will be on recap, that is physiology of third stage of labor. We'll move on to managing third stage of labor, then soft tissue injuries, then learn about PPH, clinical components of PPH bundles, and we'll give you a short 5-minute break after that and move on to response to refractory PPH and supportive measures. And then we have some online live demonstrations and video sessions planned up in the next half an hour. And then we'll move on to non-clinical components of PPH bundle, management of retained placenta, sudden postpartum collapse and amniotic fluid embolism. And at the end, we'll have a question answer session and a post-test assessment. So there are some general instructions for all the participants who have joined with us either on Zoom or on YouTube. We request you to keep your mics on mute unless you're asked to speak. If you have any query, you may raise your hand and we will unmute you and you can click on the mic button to speak. Attempting the post-test is mandatory to receive the certificate for this workshop. And the participants can post their questions in the Q&A box and they will be answered by the panel at the end of the workshop. So we'll now begin with the pre-test questionnaire. The link is in the chat box. And I request you all to click on this link and fill in the pre-test. You have 15 minutes to fill your responses. For those participants who have joined us on Zoom, the link is in the description box below. Once you click on the description box, you'll see the link to the pre-test. You can click on that link and attempt your answers. You all have last 10 minutes to attempt the pre-test questionnaire. The link is in the chat box. Please click on the link and it will take you to the Google Forms where the pre-test questionnaire is there. You can submit your responses after that. For those of us who have joined us on YouTube, the link is in the description box. There are 15 questions in the pre-test. Please make sure you answer all the questions. You have another 7 minutes remaining. Last 5 minutes are remaining. Please attempt all 15 questions and then click on submit. Last 2 minutes for the questionnaire. The link is in the chat box. Okay, so the time for the pre-test is up now. I hope you all have clicked on submit so that your responses can be recorded. And without further ado, we now move on to the first session. We have Dr. Vikram Datta sir. Sir is Director Professor at Department of Neonatology, Lady Hardinge Medical College, New Delhi. He is the President of Nationwide Quality of Care Network. He is a co-chairperson at QI Cell, Kalavati Saran Children's Hospital, Lady Hardinge Medical College. He is the coordinator and executive member at Development and Supportive Care Foundation for Newborn and Children. Sir is an ISQA expert for 18 to 2023. Sir is a guest editor for the years 2020 to 2021 for the BMJ Open Quality South Asia edition. Sir is the lead National Mentoring Group and Technical Resource Group lead for Sustainable Model for Lakshya. He is a member QED Working Group at Ministry of Health and Family Welfare, India, and a member of National Editorial Board till 2017 in the Indian Journal of Pediatrics. And Sir is editor-in-chief. Sir was an editor-in-chief till 2014 for Journal of Neonatology, India. We welcome you, sir, and to declare this workshop open and give an introduction to this workshop.
Thank you so much, Ashna. A very warm welcome to all the participants, respected Chawla Madam, and all my colleagues, Dr. Bangal sir, Dr. Poonam, Dr. Prabha, Dr. Preeti, Dr. Anupa, and all my colleagues who have joined on this Saturday afternoon. And I hope that this session is going to start with the blessings of Chawla Madam, who's been a teacher to all of us and has joined from Sevagram despite her very busy schedule. And we will have a series of such skill building workshops ahead, which will pave the way for building up obstetrics skill and harnessing the qualities improvement movement across India. So without wasting much time, I will very briefly take you through a small presentation which will just give you a feel of what this is all about and why we as a quality improvement organization have decided to move into the domains of clinical skill building besides the quality improvement, and where do these two things wed. So a very warm good afternoon to all my friends from across India and the respected faculty and my eminent panelists. We all know that safe motherhood is one of the most cherished dreams of every woman, and making this dream come true is the prime duty of all obstetric care providers. This is a saying which goes without saying. But when I think about this, I take you to a special bulletin of Government of India, the SRS system, which in 2015-17 data, which was released in November 2019, this is the latest data, it shows that the MMR has declined from 130 to 122 over 2015-17. Now, this decline has been most significant in the EAG states and Assam from 188 to 175. And from other southern states also the decline has been quite significant. Well, this is a matter of great pride for all of us, and this speaks volumes about the hard work which all our obstetric teams and the obstetrics and gynecology colleagues across the country are doing with Government of India and the various national health missions. Now the question before us is that we have to reach a SDG target of 70. So how to reduce the MMR further? That is the target behind in front of all of us. So if I look at a quality improvement perspective from the studies of the Better Birth trial, which is one of the largest studies done on quality improvement, and the SCC checklist, which has been adapted in Uttar Pradesh by my friends from the Harvard School of Public Health, the Radney Lab. They're basically 4 barriers which prevent a team from effectively utilizing the quality improvement and evidence-based practices into direct care of the patient. And the first and the most important part which we are going to concentrate today is the ability component. The ability is basically seen as a deficiency in the birth attendant's skill or knowledge. And you all know that without the ability or the skill, we cannot deliver quality. And that is precisely the reason why I've come to this aspect, is that NQCN is now focusing on skill building sessions like this. We've had previous sessions on RMC, we've had sessions on neonatal resuscitation, and now today this is the session which is going to take it forward, and we're going to have a host of sessions like this. Now, if you look at the maternal mortality rate of our country, we have states with the lowest MMR. Some of these states have already met the SDG target. When I look at Kerala, Maharashtra, and Tamil Nadu, they're already below 70, and 2 states are on their way to meet the SDG targets. But on the right side of my slide, if you look at the states with the highest MMR, then these are the states like Assam, Uttar Pradesh, Madhya Pradesh, Rajasthan, and Orissa, which are going to find it very, very challenging to meet the SDG target of 70. And these are the states with highest MMR. So what I mean to show here is that India is a country within countries. You know, we've got multiple, contextual problems, states with multiple health indices, which are way up or way below the national average and the international average. And we need to address it as a nation jointly, picking up the contextual problems and trying to fix them using a blend of skill building as well as quality improvement. Now, I'm showing you a photograph of a district hospital where there is a special newborn care hospital. This is through one of my last, physical visits, November 2019, to Uttar Pradesh district hospital. And this is a remote district hospital in Uttar Pradesh. It's in one of the aspirational districts. You can see the SNCU. Looks pretty well. So what do you think about this hospital's quality of care system? Do you feel that probably, yes, they're doing a pretty decent job? The administration is sensitized to quality and they're probably looking at quality from a different perspective. The skills are getting built up. So the SNCU looks pretty clean, pretty organized. Processes seem to be followed. It's very difficult to tell from this snapshot, but that is what we felt till the time that we visited the labor room of the same district hospital. The plug is out, the equipment, the scissors, the forceps, etc., they are all lying in cold water. There's a trash bin here. You can see all mixed type of trashes, including blood-soaked napkins which are there. And this is the hand washing station. And this is a mug with which the doctors and the healthcare providers wash their hands. And surprisingly, there is no soap. Well, what do you say about this? the same hospital, the SNCU, and the same hospital, the labor room. Is there any dearth of resources? The answer is probably no. Is there dearth of manpower? The answer is probably no. The same manpower may be there, or maybe they have a different set of manpower for this. But definitely there is an attitudinal problem. Are the mothers being more neglected than the newborns? And what do I expect these newborns who land up in my SNCU being born in a labor room, which is like this? And I am not showing multiple photographs from this labor room. That brings me to the answer that we've raised our institutional delivery rates close to 90%. But have we fixed our key process indicators, which are still suboptimal? And you can see here all the key process indicators less than 50%. Mothers not getting postnatal visits, emergency obstetric care, subtherapeutic levels, early initiation of breastfeeding less than 50%, antenatal care less than 50%. So the question which comes before our minds is coverage equivalent to quality healthcare? And the answer is that if I chart the data and I just look at the neonatal mortality rate per 1,000, you'll see that the percentage of births that occur in health facility, close to 100%. It can range from neonatal mortality rates pretty high in states like UP, Chhattisgarh, etc., to states like Maharashtra, Manipur, etc., where even though the deliveries are not occurring in health facility, or Maharashtra, where many of the deliveries are occurring in health facility, the NMR is quite low. So it means that coverage is not equivalent to quality in India. So the new mantra is that the utilization rates of health services, if are close to 90 to 100%, how can we assure health to the community? The missing link here is quality. So if my utilization rate is 100%, but my quality is 0%, then my health outcome is going to be a big query. And that is what we want to tell you. So utilization 100%, quality good, our health outcomes are going to be good. So how do we reduce this variation and decrease our NMR to achieve international targets? There are lots of solutions which come out and through brainstormings, and I'm sure today also we are going to talk about how to make sure what Dr. Bangal and his team are going to talk to all of you are going to be practiced in real time in field settings. That is very, very important, and these are all the possible answers which you guys are going to give. You're going to say, let's build infrastructure, let's get more HR, let's incentivize work, let's motivate people, let's involve community in healthcare, and let's do an accreditation program. Well, these are some things. But my question to you would be, at the end of this workshop, just question yourself, do these solutions work, and how long do you think they are going to sustain your improvement? So globally, if you look at poor quality kills 5 million people, far more than the numbers who failed to reach the hospitals. And hence, we need to fix the poor quality. And 2018, 19, 20 is an era of global universal health coverage. And these are the SDG goals. And 3.8 SDG says achieve UHC. And India, by declaring Ayushman Bharat, trying to implement it in letter and spirit, we are trying to achieve UHC. But the question which stares us blankly in our faces, we know the best practices. Dr. Bangal is going to teach you the best practices with his eminent team today. But how to ensure that your team follows these best practices at point of care? So let's see the systematic review which has come out in Lancet, which looks at what improves the health worker performance. And if you look at that, if we just train, it is going to only lead to a 10% effect size. Means 90% people are going to miss out. They're not going to change the way they are going to work. But if you involve them into a quality improvement program with training, as is going to happen today, the largest effect size is 56%. And that is making a case for quality improvement. And that's precisely the reason why NQOCN has teamed with Foxy and ICOG to take this message forward and synergize quality with skill building. So our need of the hour is that let's not only increase our knowledge with theoretical sessions, but also increase in commensurate manner that whatever we know, we practice at the field levels. So the need of the hour is not trainings and developing guidelines and monitorings and incentives, but quality improvement approach. And this is what is going to lead to a system building and a hardwiring of this. So finally, to end, I would just like to give message to the administrators and the senior administrators and my teachers who are sitting here that mere knowledge does not translate to on-ground action. We've seen it. We have to work simultaneously to create an enabling environment and skills and motivation of teams to provide adequate resources for teams to function optimally. We have to identify the bottlenecks and work on them as a team using a problem-solving approach, not a finger-pointing approach. That is something which is very, very important. And use simple point of care quality improvement methodology to bridge the no-do gap and synergize your work with the national targets. Well, that is something we all forget sometimes, that they are national targets, they are global targets set by WHO, by the Ministry of Health and Family Welfare. For example, we have the Lakshya program. So let's very quickly, let's synergize, and the combination of QI skills plus clinical skills is what will help us to achieve the SDG 2030 goals. So thanking you so much. So we are here to provide an enabling environment coupled together with quality improvement, and this is together with the clinical skills, and that is going to make this sapling grow, and we are all going to be nurturing it. So I bring greetings from the NQC and point of care quality improvement communities of practice and all the national and international partners, and welcome you to this session. Thank you so much. Dr. Bangal, over to you, sir.
Thank you so much, sir. So to inaugurate the workshop, we have Dr. S. Chabra ma'am and Dr. Archana Verma ma'am. So I welcome you both. Professor Shakuntala Chabra ma'am is working as Emeritus Professor X Head of Obstetrics and Gynecology at Dean at MGIMS Sevagram. She is Chief Executive Officer for Women and Child Welfare Center, Akanksha at Sevagram, Wardha, and Officer on Special Duty for Dr. Sushila Nair Hospital, Amravati, Maharashtra. She's a technical advisor for Incline Trust International. She has won the Lifetime Achievement Award in 2018 by Association of Gynecological Oncologists of India. She's also won the Unsung Heroes Award by the Federation of Obstetrics and Gynecological Societies of India. And she's a member of Working Group on Women and Children and Adolescents World Federation of Public Health Associations, World Rural Health Council, Women and Health, Together for All. And she's a governing council at ICMR, Government of India, New Delhi. She's an assessor at NAC, and she's a chairperson for the Scientific Advisory Council, National Institute Research in Reproductive Health. And she has a very strong research background with over 500 research publications to her credit and over 1400 citations in Google Scholar Citations. We welcome you, ma'am. And for the next, we have Dr. Archana Verma, ma'am. She is Vice President-elect at FOXY and Associate Member of RCOG. She's a founder president of West UP chapter. She's an organizing chairperson of the UP COG 2020. She's the organizing secretary for the North Zone Yuva Foxy 2016, UP ISAR 2015, and Midterm UP COG 2015. She's very passionate about creating awareness on women health. She's a chairperson for Public Awareness Committee at Foxy 2016-2018. She's a member at Rotary Lions Ekta and Udan BVP. She's a president at Foxy and Best Committee Appreciation Award recipient. She's a UP governor at Uttarakhand Governor Appreciation Award for Menstrual Hygiene. And she has won the Appreciation Award from CRPF Director for Health Programs 2019 and the Women of the Year Health Award from IAS Vice Association. And she's a faculty in 300 plus national and international CMEs. So we welcome you, ma'am, and over to you to give a brief talk about the inauguration of the workshop.
I'm supposed to say first.
Hello.
Yes,
Hello,
ma'am. We
go
can
ahead,
begin with
please.
Chabra, ma'am.
Hello,
Yes, ma'am.
Yes,
We can
ma'am.
hear you.
can you hear me?
Yes, ma'am.
Yes, we can hear you.
Good afternoon, everybody. Let me compliment to all of you for having taken this subject, which is very, very important today, especially in India when we are trying to reach what is our target. And qualities, we blame rural women, but it is most important that we assure that there is quality. And the theme of today is something which all of us know, obstetricians are here, that this is where the bottleneck is. If we have to come nationally, we have to reach the goal which we have got. So I know there is a time shortage. If I start talking about catastrophes, 6:30 will not be enough. I will keep on talking about 24 hours, maybe more than that. Bengal knows, Poonam knows and all, because we have been talking about these issues over the years, I should say. I will not take any of your time. I would like to thank the team, Dr. Datta, Dr. Bangal, and everyone, and all my best wishes for whatever you have planned, because quality is very, very dear to my heart. I remember Dr. Bansal actually giving me a compliment that usually obstetricians blame that the women come quite late. I accepted that there are quality issues from entry to exit at medical colleges also. Why a woman, dying woman, we shouldn't be able to save, and why a post-Caesar patient should die. That's our quality, which we have to always, always remember. So all the best from my side. There are only 10 minutes for this whole thing, so I won't take like Dr. Archana Verma speak about this whole subject, and then you can go ahead. I'm sorry, I will have to leave in between because I'm supposed to be chairing a session at 3 o'clock. So that's why I won't be able to be with you. That's 3 to 4:30. So that also is a national program, and I had committed to that much earlier than this program. So all my best wishes for everything. Thank you.
Very good afternoon, everyone, and I'm really delighted to meet Madam Chabra personally, and my salute to her. She is really not unsung hero. She is a very well-known person, and I'm very much thankful to the President Vikram Datta sir and Bengal sir and Poonamji for giving me opportunity, such a big opportunity for such a big program. And definitely, we all are striving for our women and working for the together for the SDG goals is definitely going to help a lot, and such a nicely crafted program. I must congratulate you. I have never seen, rather I have never seen, because I am not in from medical college I'm in private practice for last so many years. So this is a much and much and much highly excellent program, and I must say that a leader has to have a vision and a goal, and to come out and clear all the barriers whatever they, and with the commitment, and obviously creating an environment where all the juniors also feel. I think I got mute. So this setting leader setting a vision and goals, and all the juniors feeling quite happy in that environment where all the commitments and communications are being done, and this is only possible when such a great team is there. And I think this is a wonderful program, and I must say, and I don't think I was totally this unmuted before, and I must have heard my first one, and I'm really thankful to and obliged, and wish all the best. What a great program, and all the success. And we definitely need this, because in India, and especially in Uttar Pradesh, I'm from Uttar Pradesh, I'm just looking at, and really surprising that, and with this and all I really pledge and my commitment for the just doing this work, and giving awareness to each and everyone. And today's highly successful registration also just say how people need skills, and definitely this making all feel confident, or because of they are getting a skill, is a need of the hour. Thank you, Dr. Bangal. Thank you very
Thank you so
much.
much,
And Dr.
sir.
Vikram sir. Namaskar, sir.
Thank you so much for your wonderful words, ma'am. Now, without further ado, we'll now begin with the first session of the day, which will be taken up by Dr. Anupa Khanna Vig, ma'am. She is of MBBS, DNB, OBGY, and DGO CPS, FCPS, and a fellowship in minimal access surgery. She's also done advanced course in IVF. She's currently working as consultant telemedicine in Piramal Swast, and she's a technical resource group member for data generation and use by healthcare providers as notified by Ministry of Health and Family Welfare. She's also governing board member with NQCN and a member national mentoring group for Lakshya. We welcome you, ma'am, and we request you to speak on the topic recap of physiology of third stage of labor. Over to you, ma'am. You can share your screen now.
Thank you so much, Ashna. Thank you so much for that introduction. So, starting with the million-dollar question, am I visible and am I audible?
Yes.
Yes.
Yes, on both the counts.
Thank you so much. So, very good afternoon to everyone, and I will be kickstarting the technical sessions for the day. And I would really like to thank NQOCN, Dr. Vikram Datta and his entire team for this opportunity to be able to share the platform with such stalwarts from the field of obstetrics and gynecology, Madam Chabra, Dr. Bangal, whom I always look up to and I have learned a lot from. Dr. Poonam Shivkumar, Madam may not know me personally, but she has been instrumental in my skill building in the field of obstetrics and gynecology, whether it was, respectful maternity care or blood transfusions in obstetrics, or even to the implementation of whatever the guidelines are issued from the Ministry of Health and Family Welfare. And Dr. Archana Verma, who for the past so many months has been, arranging an academic feast, if I can say, for all us obstetricians. So it's an absolute honor to be able to share the platform with all of you. So thank you so much for this opportunity. And I will jump right away to the topic given to me for the day, which is the physiology of third stage of labor. A very basic topic. It takes us back to the days when we started as MBBS students or nursing students, or those of you who are already doing MBBS. I think it is one of the initial topics when you start studying obstetrics is taught to all of us. But a very important topic, because unless we don't know what the physiology of the third stage of labor is, we will not know what the deviation from this physiology is. So whenever there is a deviation from this normal physiology, it leads to all those complications about which we would be learning in the due process of this workshop today. And we will also be learning how to manage those very complications. So by definition, the third stage of labor is that stage which begins after the delivery of the fetus and ends with the delivery of the placenta with the membranes. So rightfully, it is also known as the placental phase of labor. Duration of this phase typically is from 5 minutes to 30 minutes, but we can wait even up to a period of 1 hour, provided there is no complication, bleeding during this phase. So there are basically 3 physiological processes which are going on during this phase of this third stage of labor. First is the placental separation, which is followed by the descent of the placenta, and finally it ends with the delivery of not only the placenta but also the membranes. Coming to placental separation, all of us know that the uterus has this typical quality or the property of contracting and retracting. So the baby is born, the uterine cavity is empty, and immediately after delivery of the baby, the uterine cavity comes down, or the size of the uterus comes down to almost 60 to 70%. So what we see in the first diagram here is that this is the normal when the contractions haven't started. But when you compare the thickness of the uterine musculature in the diagram B, you can see the retraction has also started and the uterine cavity is suddenly starting to decrease in size. This is the property of the uterus and the uterine musculature. But the property of the placenta is that it is not elastic. It cannot accommodate itself to the decreasing surface area of the uterine cavity. So it starts folding on itself and it starts separating out. To explain this process a little more in depth, what happens during the retraction is that we know that the living ligatures, or that is the most important part of this placental phase, that not only do we need to have the placenta and the membranes out, we also need to achieve complete hemostasis. So that is the other thing which is going on during this phase of labor. So when with the retraction of the oblique uterine muscles, there is a pressure which is building up on the uterine vessels, and this pressure is because the muscles are actually twining around the blood vessels, and because of this pressure, the pressure starts getting back flow is there into the venous system, and the veins start building up and they start bulging. And with the next contraction, or when the pressure goes beyond the threshold level, these veins burst and the blood starts seeping between the thin septa of the spongy layer of the decidua. Why the spongy layer? Because this is the layer which is loosely packed. It has more capacity to accommodate the blood, and this finally forms the plane of separation of the placenta. So this I will try to explain with the help of diagrams. As we can see that in this first diagram, this is where the delivery hasn't happened. This is something where a normal physiology is happening before the delivery of the placenta, or before the process of separation starts. What I would like to identify is these are the uterine musculature, the uterine muscles which are there. These are the blood vessels, the uterine blood vessels, what we can see. This is the muscular layer of the uterus. This is the spongy layer. This is the intervillous space, which is from where the exchange takes place between the maternal and the fetal circulation. And this is the fetal side. So now once the retraction starts, we can see there is thickening of the uterine musculature. You can see the figure of 8, which are known as the living ligatures. They start going around the vessels and start clamping them in order to achieve hemostasis. Once that happens, we can see that the veins start bulging as the pressure keeps building in them. This is the intervillous space, and finally these burst open and blood starts seeping in this layer, which is the spongy layer of the placenta, and this blood further also helps in separation of the placenta. Here in the final diagram, what we can see is that the placenta has separated, complete hemostasis is there, the uterine muscles have nicely gone around the blood vessels, they have obliterated them, and in this delivery, there will be a complete hemostasis. So this is the diagrammatic representation of what actually is going on. Signs of separation, very briefly, all of us know that signs of separation are that the consistency of the uterus will change. There might be a suprapubic bulge. There will be a slight trickle of blood. I would like everyone to remember slight trickle of blood, because further in the next few slides, we will try and contrast this with some fresh gush of blood, which will happen during this stage of labor. And finally, there is some amount of lengthening of the cord. So there are two ways in which the placenta separates. They have been shown in this table, but I will take everyone through this very briefly. The first is the Matthew-Duncan's method, and second is the Schultz method of separation. The main difference between both of them is that where in Matthew-Duncan, the separation of the placenta starts from the periphery. In the Schultz method, in contrast, it starts from the center outwards. And because it starts from the periphery, whatever amount of blood is seeping through the spongy layer, or whatever blood is seeping during the process of separation, that trickles down, and it can appear to be a little more than the amount of blood loss which we see in the Schultz method of separation. How do you identify that which method has taken place during the delivery which you are conducting? Is when you see the placenta which has been delivered. In Matthew-Duncan, the surface which appears at the introitus first is the maternal surface of the placenta, where the cotyledons can be identified, whereas in Schultz, it's exactly the opposite. The surface which appears at the introitus first is the placental surface, and we would be able to see the placental membranes shining. So something which my teachers had taught me how to remember is a mnemonic which I'm going to share with all of you. So the first is the Schultz method, where you see the fetal part of the placenta appearing first at the introitus, which is shiny. So it is shiny Schultz. And as I said in Matthew Duncan, it is first the maternal surface where you will be able to see the cotyledons. And so it is often called the dirty Duncan. It's just a mnemonic to remember which separation has taken place in our patient. So after the separation is complete, like the fetus, now the placenta also needs to be delivered. So the descent happens when the placenta is descending and is going to be delivered. And here you can see a fresh gush of blood. This is something which we need to identify and contrast from the trickle of blood, the fresh gush of blood. So this shows that the placenta has delivered. I mean, it has descended and it will be delivered in due course of time. There is a lengthening of cord and finally the shape of the uterus further changes. This is a small diagram which is showing the first two processes, that is the separation as well as the descent of the placenta. The first is the Duncan's method. We can see that the separation has started from the margins, and this is the length of the cord. Finally, when the descent of the placenta is happening, we can see the lengthening of the cord, the true lengthening of the cord has occurred, and there is a longer cord which is hanging out of the introitus. And finally, there is the delivery of the placenta where the maternal surface of the placenta is visible at the introitus first. And that is in contrast to the Schulz method, where you can see that the separation has started from the center. At the margins, the placenta still seems to be attached. So there is no trickle of blood. And this is the cord again. When it's being, the placenta is being delivered, we can see again the length of the cord will increase. There will be a gush of blood. And the surface which appears at the introitus first in this case is going to be the placental surface. So finally, coming to the expulsion of the membranes, I must here make a comment that the expulsion of the membranes at times is because of the uterine contractions, and also a big hand in the expulsion of the membranes is because of the traction which is exerted by the delivered placenta or the placenta which is descending. And the terminology which is used for this separation of the membranes is typically the stripping of the membranes. So finally, with the placenta, the entire membranes are stripped and the placenta with the membranes are delivered. Finally, what occurs in this stage and what we all aim to achieve is a good hemostasis, because as we go on, we will realize that PPH is one of the dreaded complications of labor and delivery. So finally, this stage ends with achieving good hemostasis. And that is all that I actually have to share. A very basic topic, but I feel that sometimes knowing the basics often helps us to know what is, away from the normal physiology, helps us to act and react in time. And that is what makes all the difference. So thank you so much. Over to you, Dr. Ashna.
Thank you so much, ma'am, for that wonderful presentation. We now move on to the next topic. And for that, we have our next speaker, that is Dr. Anuja Bhalerao, ma'am. Ma'am is professor at OBGYN department, NKP SIMS Nagpur. She has 29 years of teaching experience, and she has done a fellowship in urogynecology in USA. She's also received the Best Teachers Award and the Best Research Project Award. She's a faculty at national and international conferences and an operating faculty in Urogyne. She also has 32 publications in national and international journals, and she has investigated in WHO PPH bundle project with Harvard University, USA, and a national cricket player, and has 24 hours of solo power trying to her credit. So ma'am will be talking about managing third stage of labor, and we invite you now, ma'am, to share your screen with your presentation.
Thank you so much, Ashna. Is my screen visible now? Hello?
Yes, ma'am, we can see your screen. Yes, we can see your screen, ma'am.
Okay, thank you so much. Good afternoon, ladies and gentlemen. At the outset, I would like...
Show, ma'am? Yeah.
Yeah. Is it okay now?
Yes, that's good.
Okay.
Thank you, ma'am.
At the outset, I would like to thank Professor Vikram Datta and Dr. Vidyadhar Bangal sir for giving me this opportunity to be part of this very important topic, and discussing about management of third stage of labor. Well, ladies and gentlemen, management of third stage of labor is important because of its association with various catastrophes that we are going to see in due course of time. Third stage of labor, as we all know, is a very critical stage which starts from the delivery of the baby to delivery of placenta and membranes. And as has been rightly explained by Dr. Anupa wonderfully in the previous lecture, the duration ranges from 5 minutes to 30 minutes. This topic of third stage of labor is really intriguous because about 2.8 million women from low and middle income group are dying because of this. And the most important reason that has been sought is because the interventions that are available, which are evidence-based, are not used correctly. Whenever we fiddle with the third stage of labor, it is associated with third stage hemorrhage, leading to a catastrophe, that is postpartum hemorrhage, and sometimes we can have retained placenta. The bleeding that occurs during this stage, and at that time, every second and every drop of blood matters, because we all are working here to save mothers, to have safe delivery for them, and to stop PPH. Before we really go into the active management of third stage, let's see why placenta separates. My previous speaker has already told that, but just let's revise once again. After the delivery of the baby, there's decrease in the size of the uterine cavity because of the uterine contraction. But what happens is that a placenta is rigid and inelastic. So it has to accommodate itself in that small cavity now, it folds on itself. And as it folds on itself, there's some amount of shearing that occurs between the spongy layer of decidua basalis and the placenta. And then whenever there's shearing, the vessels open up, form a retroplacental hematoma. And as has been already told, the separation may be a central separation, which is called as a Schultz separation, and it can be marginal, called as Matthew Duncan's. There are various signs of placental separation when the placenta separates from the uterine cavity through the spongy layer of decidua basalis. You have certain vulval signs, like there's a gush of bleeding, or when the placenta is about to deliver, you will be able to see the placenta. There's permanent lengthening of the cord. When you compress on the suprapubic area, the cord doesn't recede. The uterus slightly increases in size, and the uterus becomes like a cricket ball. But the presence of the placenta at the vulva is a definitive sign of placental separation. Rest of the signs you might even get when there is partial separation of the placenta. These are the various diagrams which are depicting the separation of the placenta and its expulsion through the vulva. The placental separation from the placental site, as we all have seen, is because of the uterine contraction, which plays a very important role. And as I have told you, that the separation occurs through the spongy layer of decidua basalis. Now here I would like to just mention something about a membrane, which is a very important membrane for us, that is called as the Nita-Bukes membrane, also called as a fibrinoid layer that separates the decidua basalis from the placental villi. Now, whenever this Nita-Bukes membrane is absent, the placenta directly encroaches on the myometrium and leads to placenta accreta, or also called as placenta accreta syndrome, where it gets incorporated into the myometrium and it would not separate so easily during the third stage of labor. The bleeding stops because of the crisscross arrangement of the muscle fibers, also called as myotamponade living ligatures, where the vessels are entrapped between these muscle fibers. There's opposition of the walls of the vessel, there's formation of a clot, ischemia occurs, and the bleeding stops. This is how bleeding usually stops in patients after delivery. But if this doesn't happen, if there's uterine atony, if there's improper separation of placenta leading to improper uterine contraction, patients usually bleed from the spiral arterioles and veins leading to PPH, and hence the topic of management of third stage of labor is so very important. Longer the duration, more will be the PPH. The average span is between 5 minutes to 6 minutes. In 90% of patients, you find that placenta separates within 15 minutes. And if you happen to see 97%, it takes 30 minutes. In preterm deliveries, it might take a bit longer. And why it is important to know about retained placenta? Because it's usually then needs to be removed under GA, and so an intervention is required. Basically, there are two types of management of third stage. One is expectant management, also called as watchful expectancy, where spontaneous delivery of placenta occurs without the use of any uterotonic agents or cord traction. The placenta is delivered by maternal expulsive forces and gravitational force. It takes more time and is associated with more bleeding. The very important when we talk about other very important management of third stage is active management of third stage of labor. Now, what is active management of third stage? These are the various steps, I mean to say, which are taken immediately following the birth of the baby to decrease the risk of PPH. Today, we all have gathered here to talk about PPH as a bundle approach. And we are going to see so many components of this bundle. But when we talk about active management of third stage of labor, it is also a type of a small bundle which has got various elements that we are going to talk of in the next few slides. So it is a part of a bundle that is so very important in prevention or decreasing the risk of PPH during the delivery of the baby. When we started with active management of third stage of labor, there were 5 components to start with. Administration of uterotonic after the delivery of the baby, controlled cord traction method, slow delivery of the baby, uterine massage, and early cord clamping. Urinary bladder should be emptied in all cases. But there were so many RCTs and so many Cochrane data that went into the analysis, and they found that early cord clamping need not be included now in the third stage of labor, because if you do early cord clamping, less amount of blood is then going to the baby and the baby might land up in anemia. So now, according to the FIGO and ICM definition, the active management of third stage of labor includes only 3 things. Use of uterotonic immediately following the delivery of the fetus, controlled cord traction method to deliver the placenta, and doing fundal massage immediately after delivery of placenta. This fundal massage that we talk of, we have to palpate the uterus every 15 minutes for 2 hours to assess the continued need for massage in a patient who shows small amount of trickle. Now, the first component of the third stage of labor is use of uterotonics. Uterotonics are to be given within 1 minute of the delivery of the baby. The various uterotonics that are used are oxytocin, which can be given intramuscularly or IV, 10 international units, but we have to be very careful whether it has been kept in the cold temperature between 2 to 8 degrees and has not been exposed to light. Otherwise, the potency of oxytocin will become less. Now, other drug that can be used is methyl ergometrine 0.2 milligram IV or IM. We have to be very cautious of its use in patients with anemia or in patients with heart disease. This is an ergot alkaloid, makes the uterus contract and retract. The third drug that is available with us is PG-even analog, that is misoprostol, which can be used 400 microgram or 600 microgram per orally. This can be kept in the room temperature, and so it can be used everywhere. The carbetocin 100 microgram or oxytocin and ergometrin fixed dose combinations can also be used. But friends, whenever we are giving uterotonics, we have to rule out that there is no multiple pregnancy after the delivery of the first baby. So you have to rule out multiple pregnancy and then give uterotonic within 1 minute of the delivery of the baby. After the use of uterotonic, we have to deliver or facilitate the placental delivery by controlled cord traction method, which is recommended by WHO, which is called as Brand-Andrews maneuver. Now, this Brand-Andrews maneuver is one where with the left hand, you are going to push the uterus up, and with the right hand, after the signs of separation of placenta, a controlled cord traction method is given so that the placenta is delivered. Now, this controlled cord traction method, though has been recommended by WHO, it is optional at certain times, because if there is no person who's skilled one or a skilled birth attendant is not available, then if the pull is given before the separation of placenta, it can lead to inversion or cord avulsion, or there can be incomplete removal of the placenta. So in these cases, one has to be very fast to remove the placenta manually by MRP. These are the various pictures which are depicting the placental separation. We are seeing all the signs of separation of placenta, and then how do we give the controlled cord traction method, and how do we deliver the placenta and shearing of the membranes by rotating the placenta and delivering it totally, putting it in a bowl of water and putting it on the table and seeing whether all the cotyledons are out or not. After the placenta has already been examined, the most important third step of active management of third stage of labor is uterine massage. You feel for the fundus to see what's the tone of the uterus. Start massaging it and see that the tone is well appreciated. If you're not able to feel the tone well, or if the uterotonics are not available, and if you're finding there is PPH, you continue to do massage, because this is the first step of management of PPH. And we need to see and do massage every 15 minutes for a span of 2 hours. So practically speaking, to summarize, active management of third stage of labor is after the delivery of the baby, within 1 minute, you give uterotonic, wait for all the signs of separation of placenta, do a controlled cord traction method by Brand-Andrews, and then massage the uterus. Evidence also says that there are so many positive and some negative things about active management of third stage. RCTs and Cochrane data says that active management reduces the blood loss, it reduces the mean birth weight of the baby at times, and reduces the need for maternal blood transfusion. However, it is associated with vomiting, after pains, use of analgesia from birth up to discharge, and they have found that there are some women who return to hospital with bleeding. So active management reduces the incidence of maternal anemia by preventing PPH, but sometimes there may be associated postnatal hypertension and pain and return to hospital due to bleeding. So ladies and gentlemen, we need to find inroads in this unknown horizons by evolution and learning, because we all are here for safe delivery, saving mothers, and stopping PPH. Thanks a lot.
Thanks a lot, ma'am. So with that wonderful presentation, we now move on to the next presentation. And for that, we again have Dr. Archana Verma, ma'am. And ma'am will be talking about soft tissue injuries during labor, prevention and management.
Yes, okay. I will try. Okay, thank you very much. Just let me share my screen. Ashna, you are sharing my slides, or?
Okay, I'll share it for you, ma'am.
Okay, okay. So now I don't have to do anything. So, dear friends, we should start directly because of the shortage of time. And though each patient showed all have a dream of a positive experience of a pregnancy and delivery, and in for this we always try to do from our side, but it is not true for all, and many of them have the reasons for having the horror stories of childbirth. Though we talk about MMR, maternal mortality, which has come down with a very good news, as it was shown by the our previous president, and from it from 130 to 122, but that is also unacceptably high. But to have a quality care and to have access to quality care, they are both are very different. And safe delivery is definitely the right of a woman, and we all should try to do that, because we need to talk about the disabilities and pains and injuries also, which a patient may have during the delivery, because our baby is being born and there are chances to injury to birth canal. Next slide, please. And so in the this whenever after in the delivery we expect many all the reproductive organs, they can be injured, like uterus and cervical and perineum and pelvic hematomas, they all form because of the so many in, kind of injuries, and because of the so many reasons which we'll be knowing very soon. Next slide. So first of all, we talk about the take the rupture of the uterus. This rupture of the uterus is very rare but catastrophic obstetric emergency, and it's having mainly bigger and bigger and very bad effects on a patient health. Also morbidity is there, and there are chances of very high perinatal mortality for the fetus also suffers, and it is generally during labor. Next slide. Because it can happen in the antenatal part also. And this is we must know the uterus is maybe having scars or on edge of previous operations, and that causes more prone to for the rupture, and if we know them we can do better. And next slide please, because हमको जल्दी जल्दी भी करना है ना, time कम है. So first of all, then when the uterus is not scarred and it's normal, and then it has got mainly in the developing countries. In the developed countries this is not seen, and though it is also rare, but it is there. And chance, because of mainly it is because of the high parity, because fifth and sixth gravid are delivering, and there is chances of contracted pelvis and disproportion in the pelvis, and over distension of the uterus can also be there because of the certain hydromnios and multiple pregnancy and obstructed labor. And there's a sometimes generalized uterine weaknesses also, maybe because of the previous MRPs, or sometimes congenital also. And trauma, this is we are more concerned for this is iatrogenic. And next slide please. We are doing many maneuvers also, and unnecessary and untimely pushing of the baby, and applying instruments delivery. And another is a rupture of the scar. This is in developed countries, this is very whatever ruptures occur, they are because they fall into this group only of when they are doing a vaginal delivery after previous even 2 cesarean, and they are giving 2 lakh. Next slide. And this rupture can be when it's through and through the muscular wall of the uterus, and this is called complete, and it is a fetus and the placenta, they are delivered inside abdomen, and there is significant hemorrhage, and patient is generally in shock. And the incomplete one is sometimes also called scar dehiscence, or the separation of this scar is there, and you can see when so many times without any complaints we've detected on this when we are doing cesarean, that all the fetal skull scalp is we can see hairs also, but mucosa is over there, and because there is no bleeding, no disruption, so patient is generally not in shock. Next slide. And the risk factors we if we come to see, if we know the risk factors, we can prevent it definitely, because with the increasing age there are chances of more rupture, and there is if more than one previous cesarean delivery and some this previous uterine rupture, if there is a history, then she is more prone to uterine rupture in the next one of this scar, because this scar is generally weak and we need to counsel the patient to avoid pregnancy. And the previous scars, minimum chances of rupture are in the low transverse and low vertical, and inverted T and J shaped we have more chances. And in the induction, with the augmentation of the labor, it's more, there are more chances with the oxytocin. Next slide, please. So we must avoid this augmentation in the this thing. And this scar, we when we see the scar, we can just make out that lower segment scar are definitely better when we talk about the scar integrity and the number of the cesareans, previous cesareans, and short inter delivery interval is very, very important to know that. Basically, if we take it 24 months, it will be better, but less than 18 months, definitely patients is more risk. Though we used to say that it hardly makes any difference and she can become can carry on the pregnancy if she has become pregnant. And the scar tendon thickness within a 1 week of delivery found in the ultrasound, if it's less than 2 millimeters, it's quite productive. Next slide. And then if it is more than 4.5, then we can say that we can just look for the wait for the normal delivery. And for the clinical diagnosis, though the initial features are very non-specific and it is making the even the diagnosis and management quite difficult, but the common presenting symptoms are sudden severe abdominal pain, and it is the pain is persisting even without the contractions. And there is sometimes patient feels in the tip of the shoulder because of the hemoperitoneum, and bleeding per vaginum is also so many times visible. And there is a sudden station loss of the baby when you do the PV examination, like 3 hours or 4 hours before it was at 1 station or -1 station, and then when you do this with the slight spotting, when you do the PV, then you find that it has lost the station, and there is a there is a sudden development of the fetal distress and profound bradycardia are there, and suddenly the contractions stops, and you can palpate the fetal part superficially. And sometimes there is a hematuria. Sorry, spelling is wrong. Sometimes there is a hematuria and chances of the IUD is also there, and patient develops obstetric shock. And so many times we see that because the rupture is occurring in the second stage. Next slide, please. So you find that there's a shortening of the cord all of a sudden. And this is diagnosis sometimes can be done by the bedside ultrasound, where you can see the extraperitoneal hematoma, and there's a quite well see the myometrial defect is also seen, and there's a empty uterus, and the sac is above, or the fetal part is above, and then you can just make out that there's a. And next slide. And another this investigation is apart from all those the antenatal investigation we do, then MRI is not feasible, but it is it shows quite good diagnostic features. And the golden rule to remember is always have a high suspicion, unless and until next slide, unless and until you have a high suspicion, you won't be able to look for the rupture. And this impending rupture is where you can save the rupture. Is that there all of a sudden patient is having so many strong contraction, ek ke baad ek aa rahe, and there's a all of a sudden you see that there's a distension of the lower uterine segment. It looks like if there's a full bladder, and there's almost like a two segment happen, and this lower segment starts moving up and up and up, and there's a upper segment getting retracted, and there's some this is on PV examination you can see the edematous cervix, which is quite diagnostic of the obstructed labor. And there's a pathological, next slide, and there's sometimes a pathological rings develop that is called a Bandel's ring. And among the diagnosis, this differential diagnosis, we can keep in mind the placental abruption, but you see everything is there, but except the the uterus is very tense and tender, and then there is sometimes there is a ruptured hepatic rupture. Again, the spelling, I'm very sorry. Hepatic rupture occurs in because I made this very late, and I just couldn't time to edit it. And so there's a rupture of the this hepatic rupture, and again but there is also uterus position and contour is very well maintained, and intraamniotic infection, chorioamnitis, there is a history of fever, and again there is a contour is well maintained. Next slide. And the only diagnostic is the exploratory emergency laparotomy, and where when we do it, we do the not only for the diagnosis purpose but for the management purpose. We go for the conservative approach with the either repair or repair with the ligation. And in case of the lateral tears going into the broad ligament hematoma, which we find so many times, and there is a lot of this hemorrhage and rough tissue, and the both in that is the both side internal like artery ligation is also must, along with the repair of the rent. And then because of the we go for the this conservative approach only if the patient desires of the further future childbearing. And the next slide. And the patient's general condition is quite good, and for the definitive the golden treatment is hysterectomy. But if it is you can avoid it, then it's better. And especially when there are multiple rupture and extensive one and very bad ragged edges, and there's just after the patient resuscitation, that first stabilization of resuscitation of the patient is very, very important. Next slide, please. And so the complication of rupture, there can be many, but remember the damage to the ureter and message and obstetric shock and DIC and death also if it is not managed, and if especially patient is outside hospital and coming late. Next slide. And this whenever we are giving having a previous cesarean and going for the TOLAC, there are certain this trial of labor, then we need to remember certain contraindication, and we must see the patient individually, and just not as a ego ki we are the best obstetrician, we can do this. But if we are doing it, then just a very good care and very good intrapartum fetal monitoring is required. And absolute contraindication are if in the previous history there is a previous uterine rupture or classical cesarean section, or there's a placenta previa. Otherwise, because according to even the AOCG guidelines, you can go for this thing. Next, then preventive steps are the first of all, in the antenatal care, just identify risks and counsel high-risk patient, and there's a close fetal monitoring, and don't miss any. Next slide. Don't miss any this warning signs, and just be suspicious. Then only we can prevent it, and giving a good care and good quality care and good second stage. And then another in the injury is a cervical tear, which is very, very common, and because of the so many times there's a premature pushing because of the maybe precipitate labor, or maybe because of there's too much of augmentation of the labor. And there's sometimes when you are doing a next slide for delivery, or when there is patient has been operated for cervical cerclage, or there is any cervical scarring. And this theoretically we can this into the various degrees. This first degree, second degree, third degree, though in that emergency you're not possible. And the types are again it's both sided or the one sided. Next slide, please. And sometimes there is an annular detachment of the cervix also we need to see. And a diagnosis is only when you see there is a lot of bleeding going on, and with the left hand you find that the uterus fundus is very well contracted, and there's a patient is passing clots and there's bleeding. And then in good light, you just try to shift the patient from labor room to the OT. Next slide, so that you can better visualize and better do the management. And for this repair of the cervical tear is very important, because here all the arteries which are there, it has a tendency to recoil. So we should not give that stitches. So because later on there will be problem, and the figure of the 8 we avoid, and try to just catch hold the anterior lip of the cervix mainly, and the first sponge holder, keep the that cervical tear repair autoclave set in the with the delivery set only, and then on the mounted needle you just keep on just see the apex. To reach the apex is really very important, otherwise there will be hematoma and later on you won't be able to manage it. So that finding the apex is very important, and assistant pulls to it to one side and then you can see. And if you are not able to see the apex, then you can give the where whatever the lower part you can see from one to other, and you pass the stitch and cut it long so that you can use it as a traction. And you have to look just keep on changing the sponge holder. Next slide. To the whole to see the whole cervix up to the almost full circle of 360-degree. And the suturing is obviously this is something very only thing to remember is the laparotomy may be required if it is very high. Next slide. Then there's a one thing, something called porexis. It is a rupture of the vaginal vault or upper 1/3 of the vaginal wall. Sometimes it comes alone or sometimes it is along with the cervical tear. And the symptoms are obviously same and the management is again the same that you can repair. Next slide. From the below or if it is high up, then laparotomy may be needed. And then there comes the perineal tear. The perineal tear, if we know the anatomy, it is very well good. Good for us because there's a then one. There's a next slide. Pelvic floor and all the three important muscles. You see that where the just in this side you see what is just here you can see the external sphincter, internal sphincter, and all the columns and squamous. All the three muscles and the levator and eye, especially the levator and eye on the anatomy you must remember. And next slide. So these are the perineal tears which are you can see, and sometimes there are occult also. On the outside you don't see anything, but they from the there's a inner muscle rupture happens, and it can also lead to the next slide. There's anal incontinence. So in the risk factors again the same, the prolonged labor, obstructed labor, and when they are shoulder dystocia, big baby, breech delivery, and when sometimes giving the midline episiotomy, the not well supporting at the time when the head is a sudden extension, and so on, and especially after the instrumentation deliveries, and persistent occipito posterior where the phase 2 pubis delivery happens. Next slide. And this thing is something very important to know, that the classification of the perineal tear. We all know the first degree is the skin and the muscle, and then the second there is a skin and the mucosa, vaginal mucosa and the muscle. In the first there is only vaginal mucosa and skin, the outer skin. And this in the second degree the muscle is also involved, but the anal sphincter is spared. And in the third degree it is actually the anal sphincter is also involved, and some of the external both the internal anal sphincter is also involved, complete external, and some part of the internal anal sphincter is also involved. And in the fourth degree laceration, the rectal mucosa is also, next slide, rectal mucosa is also involved. And this, and now the latest is there is this third degree laceration is also categorized into 3A, 3B, 3C, and then the 3C is again is the same, just the it is just a newer classification. Next slide. And this photo shows this especially very nicely, that this is the first one. Upper one is a simple tear, we call it simple small tear, first degree. Then the second degree you see that there is a anal sphincter is not torn, and it is then the third degree, and this is fourth degree where the perineal muscles and everything is torn, and you can see the rectal mucosa. Next slide. And then the clinical feature again same, just same, the bleeding, too much of bleeding, hemorrhage, and sometimes because later on they can happen only and only at that time it is you who will diagnose in the good light. Next. And this repair of the perineal tear is something very important, and the basic aim is to do the perfect suturing so that the patient does not have in the future any anal incontinence and any chances of any infection or any bleeding, and there is much better maintenance of the as close to anatomy as possible. Next, please. Next. And this is again nothing very is properly again the here also the main thing is to how to do the examination under good anesthesia and your assistant and the good speculum, two speculum use, and so that you just do the upper rectal examination before repairing, so that and you push the finger up to see the mucosa is attached or not, and just feel for the sphincter, and then the apex also again very important, and just see whether it's not going very up. And the next one. And this is again the first and second degree antibiotics not necessary, and the third and fourth degree there comes the this anesthesia is required for the third and fourth degree, and a skilled obstetrician. If you are not you are not all that confident of stitching third and fourth, one should not try, because the secondary healing is very dangerous, not dangerous but not good for the patient. And then a skilled obstetrician is must, and a good anesthesia. Next. This choice of suture, again it is this polyglactin or the Vicryl is or 20 is quite good, and because it this helps in good healing and gives strength, and there's a less chances of infection and dyspareunia later on, and that and there is a no chance of wound gaping also. Next. This is a repair you see in the fourth degree laceration is present, then you have to repair the torn anal mucosa, where we give the continuous this non-locking 30 Vicryl stitches, and putting it, we used to do it so that the stitches go inside the lumen, and then the internal anal sphincter is properly identified and again repaired as a separate layer, and then you can see it glistening fascia type of a thing, and then you can make out, and the external sphincter is also identified, and you catch hold with the help of Alice, and you generally see that one end is like a dimpled to one side, and then other is retracted, and you have to do that thing. That's just make it as close as possible, and 3-4 interrupted stitches are again given, and then the this again the all the muscles and the skin as usual it is done. So next please. This end-to-end or overlapping for the this external sphincter, it is not really very it has been proved that there is hardly any difference. Whatever technique you are good, you can do it. Next. There's a post-op care also, that because the one thing is you have to take care of the general perineal hygiene and the patient pain control and avoidance of the constipation, or and giving a Foley's catheter also sometimes, or because to avoid the urinary retention if it is needed. Otherwise only stool softener should be given, and not very that heavy laxative, because it may cause certain problems, and exercises and physiotherapy is really helps a lot, and so many times within a 1 year it has been seen that there are chances of less. And if it is next, if it is not you are not able to tackle the anal sphincter, the patient will have lifelong anal the stool incontinence problem. So that is very bad for us. The preventive measure is generally we think that episiotomy is quite good enough, but nowadays it has been recommended that the routine episiotomy should be avoided, and to be given only at the time of a crowning, to avoid this too many extension of the tears, and good support at the peritoneum. That is very important. And this thing when only when you are confident of applying forceps, and then only once you, or when two, then only you do, because not only delivering baby is the issue, to give and take care of the injury is also very important. Next. And there's one thing is a pelvic hematoma, though because so many times if we don't look for them, or they are always there after sometimes patient goes into shock because of too much of bleeding inside, and then only you realize, and then majority of the time the patient is shifted from the labor room, and then they are on complaint of acute pain in the perineum, or retention of the urine, they come back to you, and then you diagnose that there was a this hematoma is there. Next slide. So if we do right at the time when you are just doing the shifting the patient, you must do a parectal examination. And even the parectal examination, even after stitching, because if any stitch is going into the rectum, you have to take care and you have to clear it and close it and cut it and again give it. And there are many types of hematoma, infralevator and infralevator. You see the levator, you saw that anatomy. So if it is below the levator, it is generally patient complains of the perineal pain, and they are limited and they are not very so much dangerous also. And you can just on examination they are easy to find. And then there's a vulval, because you see very glistening kind of a bluish or a purplish swelling which is developing slowly and slowly. And then the vulvovaginal also into the extending into the vagina. Next slide. And paravaginal is also, they are confined to inside the paravaginal and sometimes in the ischiorectal, so going to the deep into the ischiorectal fossa, and they are the hematoma which later on becomes the source for the abscess. And you just cannot find what the going on. Patient is having fever and patient is having pain, and then you miss that hematoma. Next. And these supralevators, they spread because they are above that fascia of the levator ani, and because they just go towards the broad ligament also, and then they take a very good space the retroperitoneal, and they are difficult to find out and manage, and the patient goes into the shock, and laparotomy is needed. Next. And these are the next, this is the blood supply actually, which is going, you see whether there's all the branches of the internal pudendal artery and the middle rectal artery. And sometimes there is not obvious injury, and the injuries to all these vessels, they also causes hematoma. The next is the cause are again I've already mentioned, and because the majority we are not able to fix them with the hemostasis, then there is always this hematoma formation is always there. And because sometimes you don't apply even the forceps and all, too much of pressure or too much stretching, even the ironing, people keep on doing ironing, and if the fetal head compression, it also causes next. And this infralevators, actually they are usually associated with the vaginal birth, and this I think already mentioned. And next please. And the risk factors I mentioned just discussed, because there's instrumental factor, and the more common in the primary, because this is less, perineum is very a little bit of relaxed and tight, it is there, and sometimes there are vulval varicosities also there. Next. So symptoms are again the pain and the swelling and retention of the urine many times. It is mainly the patient complaint is this, and sometimes because of the too much of a big this hematoma, which are perivaginal, because the patient cannot see outside, they will only complain whenever they are seeing anything outside. So they just keep on complaining that there's a pain, there's a heaviness, there's a pain, and patient goes into the shock because of the sometimes hypovolemia. Next. This supravaginal hematoma, again, this same, just patient there comes with a pain, and there is no vaginal symptoms, and there's maternal tachycardia and all, because sign of this thing. And with the ultrasound and other your checkups, per vaginal and per rectal, you can make out. Next. This management, again, this small hematomas, actually you can do the leave. It's very small. If it is, then with the cold compress they can go, or just antibiotic. Or I always prefer to give antibiotic, because later on if there is any abscess and all, then sometimes patient also think, and we also think we could have done it. And large hematoma should be explored, and as soon as possible. And if you have diagnosed it immediately, then you can do the suturing after clear, and just cut open and removing all the clots with the finger, and then you can close the dead space by suturing, and then, or otherwise you can do it after 24 hours or even the next one. And for the main the take home message is again we need to remember that the most obstetric, just first line is very important. To remember is that they are preventable, and because you see everywhere it was a good care which we could have prevented, and if timely giving the proper position and proper care and proper way of delivery, and just not pulling the baby and all, especially cervical tear and rupture uterus, and identify patient at risk at the antenatal time only. And the as trial of labor in previous LSCS should be selected very well, and the careful intrapartum monitoring and the proper management of the second stage and early detection and management of the perineal tear is better, always better. Thank you very much. So if I want to say that if you know safety, there is no injury. If there's no safety, you no injury. Thank you very much.
Thank you so much, ma'am, for explaining that in detail. For the next session, we have Dr. Poonam Verma Shivkumar, ma'am. She is professor and head of department OBGYN at MGIMS Sevagram, Vardha. She has done advanced training in SHRH from Uppsala University, Sweden, and clinical skills trainers training for EMOC and at CMC Vellore. She's also done advanced training in obstetrics, HDO, ICU management at Foundation Cali, Colombia. And she's also a member of PPH working group FIGO and national coordinator for PPH bundle project at MGH, Harvard, USA. She's a tag member at INCLIN, India Clin, and biomedical research in HIV ICMR, and a contributor of Government of India Toolkit and Clinical Skills Lab Manual. And she has 78 research papers and 8 chapters in international and national journals. We welcome you, ma'am, to take over the presentation and talk about clinical components, postpartum hemorrhage and management using bundles approach, general considerations. I think you're on mute, ma'am. Can you please unmute yourself?
Yeah. Am I audible now?
Yes, you're audible, ma'am.
Okay. So, very good afternoon to everybody. What I'm going to talk to you today is management of PPH with bundle approach. Also our experience in Central India, Maharashtra and Madhya Pradesh in 12 medical colleges. So to introduce, let me not just go into the details. We all know that PPH is the world's greatest cause of maternal death and we are still struggling for it. And that is why the concept of bundle approach has come. We all know that the medical management is the first choice and then only you go on to mechanical management and then you go on to the surgical management. We also know that surgical management is associated with several risks of anesthesia, surgery, blood transfusion, and so on and so forth. So what we felt is that the mechanical methods probably help better, in which uterine balloon tamponade was something which we really looked into, and we realized that it was something which can save lives, especially in the lower settings. Now, if we come on to why now we are trying to talk about PPH, so we know that anemia and in this indirectly anemia leading to PPH is the greatest cause of maternal
I'm sorry
death.
to interrupt. We cannot see your screen yet.
You can't see screen?
No, we can see you're trying to share your screen, but we can't see your PPT yet. Please try that again.
See this one. Just let me just see. Oh, नहीं, ये तो बंद हो ना।
मैडम स्टॉप शेयरिंग करके फिर दोबारा कर लीजिए।
हाँ जी, वही कर रही हूँ मैम।
If you want, I can share it for you, ma'am.
Yeah, I mean, just give me a second. I'll try.
Yeah, sure.
बहुत सारे खोल दिए। March. Can you see now?
Yes, we can see it now, ma'am.
Yes, yes.
Yes, Poonam, go ahead.
Okay. So very quickly, I have to finish that. I'm going to talk about PPH management with bundle approach and our experience of 12 medical colleges. We all know that PPH is one of the important cause of maternal death, and so we are all bothered about it. Medical methods are the choice, and then we go on to the mechanical method and then surgical method. So mechanical methods have been proved nowadays to be a very good choice over surgical method because they avoid several other complications, and UBT is one of them. So if we come on to this, we all know that we all want to reach our SDG goal, and so we want to save mothers and stop PPH. Now, there was a new era started where people started talking about the bundle approach. And let's understand that it was WHO who, along with the Gates Foundation, asked MGH Harvard University to prepare a PPH management, the emergency care, using a bundle approach training package. And so came the PPH bundle approach. Friends, we all know that this is a bundle. We all have been doing everything sporadically, but none of us ever tried to bring those things into the bundle. And then came the approach PPH bundle, which actually includes several things. Now, when you talk about PPH bundle components, these are two major components. One is non-clinical component and clinical component. Now, these two components are very, very intermingled because let's have an example that you have a very good setup where you have most, talented critical care consultant with you. You have your triage very beautifully done. You have HDU, ICU, but you are not connected to the places where from the cases are coming, cases of PPH are coming. So by the time this person or this lady reaches to you, it's already late. You receive her in triage, but you're not able to save her. So whenever it comes on to the comprehensive management of the PPH, we talk about the bundle approach where we look into clinical components and non-clinical components. Very soon, my coming colleagues are going to tell you in details about it, but we'll just share very few things with you. When you talk about non-clinical component, you are talking from the root reaching to the roof. So if there is system integration, which is the first part of the non-clinical component, this means that your every PHC, CHC, district hospital, they are all connected to the tertiary hospital. So even if one woman bleeds there, they, with the helplines, they can immediately inform, and immediately this woman can be shifted to the tertiary hospital, and you can say save her on time. System integration does not mean only bringing the women, but how do you bring her? You know, you have a referral protocol, you have transportation, you have to have accompanying person and so on and so forth, which my colleagues would be talking to you. So system integration is extremely important, and system integration in itself, the network integration in itself, is a huge big thing, which requires not only the support of tertiary care and lower setting hospitals, but also requires the support of policymakers, advocates, and so on and so forth. The second and most important clinical component is teamwork, where the whole team should come together. You should have an emergency response team where a physician, a critical care consultant, obstetricians, nurses, etc., and etc., should be there together. And in this team, they should know what are their responsibilities. Like the team should divide into 4 or 5 groups, and one should take up the responsibility of patient, one should take up the responsibility of informing people, another should take up the responsibility of supplying things, and so on and so forth. Facility readiness is something which is extremely important, because let's say a woman comes to emergency, the stretcher is not there, the person who has to take the stretcher to specialized area, that person is not there, oxytocin is not available, mesoprost is not available. So all those things will create issues, and then you will not be able to save this patient. So facility has to be ready in terms of human manpower, equipment, instrument, etc., etc. Now, advocacy is something which is very important. If you have some good practices, you need to show the world that these are the good practices and this is how one can save the women. So these good practices have to be taken up by the government of Maharashtra, MP, UP, every state, and then go to government of India, and there should be various forums where you need to present these activities and these good practices. And the last but not the least is quality improvement. Friends, to tell you, quality improvement and quality assurance are two different things. Quality improvement, you detect your mistakes and you try to correct it. Whereas quality assurance, somebody else comes and evaluates you and then you correct it. So quality improvement is something, the NQOCN is all about quality improvement. You identify your weaknesses and try and correct it. Clinical component is 0-hour management, which is called the first response, refractory management, which is later on, and then there are several referral protocols. Now, this is the bundle card which has been created by MGH, and you see this is so beautiful that it just tells you, this is basically a checklist. It tells you, have you given MTSL or not? Have you called for help or not? Do you try and massage, start IV fluid, give uterotonics and tranexamic acid, that is first response, and then you give supportive measure like treat the tears, empty the bladder, and empty the uterus. Then if it does not stop, then go ahead with the refractory PPH management, give different variety of compression, apply uterine balloon, and give anti-shock garment, and then what you will see that the patient's bleeding stops. And in the meanwhile, do supportive measures like blood transfusion. If you do not have the facility, referral, or if you have facility, go ahead with surgery. So these are clinical component. And I have already told you about the non-clinical component. Very important thing here is 3 important things which I would like to mention. Respectful maternity care. So every woman, it's the right of women to have the best care. The era has gone where we would scold, we would hit. We are out of that now. Everywhere we are talking about respectful maternity care, and your quality improvement will, automatically take you to the respectful maternity care. But for all these non-clinical methods to apply, you need a leadership. And the leader is the one who's going to take you to the best possible way of controlling PPH. Now, this was the first, the project which we took up, and we were 12 medical colleges who have done this. These were the workshops which we have conducted, and we have several follow-up meetings. We had intense discussions, success stories. We created WhatsApp group in which we discussed everything. And then we came on to the zero PPH world. So you can see these are all survivors. They're interesting stories. And these were the UBTs which we used, where we succeeded, where we failed. And then we came on to a conclusion that it's a very cost effective method, very easy to use technically. So ANMs can also use it, can be used in lower setting during transit, and it definitely reduces surgical intervention, blood transfusion, and maternal mortality. These were the medical colleges who took up all these non-clinical methods, and we did system integration in the two medical colleges here, and we could cover this whole area of Maharashtra. And the result what we got was that until this lockdown came, for 1 year and 9 months, we had no maternal death because of PPH. And this is how we went to each PHC to train the people. We had our helpline where excellent response were there. We used to receive the call. There were some undesired calls of thank you and good luck. But you see, this helped us a lot in reaching to the women early, or the women reaching to us early. The facility readiness was taken up by two other medical colleges, and they prepared the facility for teamwork, emergency response team, PPH kit, emergency tray, so on and so forth. And you can see how Dr. Bangal had gone to each and every PHC and CHC to make their facility ready. And Dr. Srinivas Gadappa also went everywhere and did this. The teamwork and communication was taken up by Bhopal and GMC Nagpur, and they went to every lower settings to make their team. You see how they have prepared the team. And in GMC Nagpur, they also went into the several quality projects where they could improve the teamwork and communication. This is just their, some data. And then, of course, the two medical colleges took up the responsibility of quality improvement, where Amravati was one of it, and another was Chandrapur. And several quality checklists were developed, quality monitoring, clinical protocols, checklists for PPH, debriefing checklist, and so on and so forth. Advocacy was done with government of Maharashtra, India. We had gone to National Innovative Portal. AMOX, we did PPH walkathon. We went to Partners Forum, where Prime Minister himself come and saw our, the site where we had put these balloons. We went to FIGO Brazil, AICOG Bangalore, Lucknow, and several webinars which are continuously going on. And we are on and on to tell you that nothing is better than having a bundle approach. So this is some picture of Dr. Anuja and Dr. Sharma, who did a lot of advocacy. What lessons we learned were, I'll just mention too, that you see, people are extremely happy that they are recognized in lower setting, and they are made to learn. So it's very, very important that we reach to the community and we do the workshops there, rather than calling them in our facility where they cannot come. And there were challenges because too many programs have been given to the people, and yet we have been looking into the sustainability, and sustainability can only come when you go into the system. So these were some suggestions. So I'll just skip these slides and tell you that wherever non-clinical and clinical bundle approach is followed, for sure you can reduce your PPH deaths, if not PPH. Thank you so much.
Thanks a lot, ma'am. That was a wonderful presentation. For the next session, I would like to invite Dr. Preeti Priyadarshini, ma'am. Ma'am is Assistant Professor at Obs-Gynae Department at AIIMS, Gorakhpur, UP. Her past experiences include Assistant Professor at OBGYN at MGIMS, Wardha, and Assistant Professor OBGYN at GMC Chandrapur. And she also has done Global Maternal Health Fellowship from Global Health Innovation Lab at Boston, US. Ma'am will be talking about clinical components of PPH bundle, PPH first response bundle, and supportive measures. So over to you, ma'am.
Thank you, Dr. Ashna. And thank you, Poonam ma'am, for you have made my job very easy. Just give me a moment till I can get to my slides share, please.
Sure. Yeah, we can see your slides now, ma'am.
Yeah. And I hope I'm audible as well.
Yes.
So today I will be speaking on a subset of the clinical components of the PPH bundle, which is the first response bundle and the supportive measures that go with it. So most commonly what happens in our wards, we have patients that are admitted with us. We routinely give active management of third stage of labor to our women. But for some women, unfortunately, the prophylaxis does not work and they land up in PPH. So as soon as you realize that you have a case of PPH in your wards, that will be the moment that you call for help in your labor ward. It is important to remember, anybody can call for help. It is better to call for help earlier, as soon as you detect, than to call late and have a catastrophe at your hands. Multiple methods, as can be seen in this slide, can be used as a call for help. It could be a phone that could be used, a landline that could be used, a mic, or even some designated person who goes and informs your teams. The earlier you call for help, the earlier you will have more hands at your disposal, and the better will be the patient management and the bleeding will stop. So how do you know that you have a PPH case at your hands? That is the first step before you even proceed to call for help. The diagnosis here will be based on the initial clinical observation of heavy or prolonged bleeding. This diagnosis has to come before the signs and symptoms of shock develop in the patient, before your patient gets tachycardiac or develops hypotension or has other changes associated with shock. We do not want to wait for these changes to develop. We want to have the buzzer as soon as a clinical diagnosis of a bleeding more than average is made for a given patient. At this point, I would like to encourage you to go back to your hospitals and have a discussion with your own teams as to what would be the most effective method to have a call for help buzzer in your settings, so that you can initiate your own emergency response teams at your own settings. Once a diagnosis of PPH has been made, we generally begin, our first response bundle is triggered, and we call for help and initiate the bundle. The bundle is to be done for every patient with PPH every given time. That is why it is called a bundle. It has 4 components, as ma'am has already mentioned: uterine massage, IV fluids, uterotonics, and tranexamic acids. Now, there is no special order to be followed. Multiple actions can be done and should be done simultaneously for any given patient. And since you have already called for help, you should have multiple providers available on the team to carry out these actions simultaneously. Most women with postpartum hemorrhage can be treated with the first response bundle alone, particularly if you're able to initiate it in a timely manner. So I'll just go through these steps one by one. Uterine massage to counteract the uterus and express clots. It is a part of the first response bundle. It should begin as soon as the diagnosis is made. And it can be begun even when someone else is calling for help or if other providers are still doing the initial examination. This massage is helpful because it helps the uterus to contract when there is atony, and it also helps to expel the clots from within the uterine cavity, which may have been causing prolonged bleeding in the case. How do we massage the uterus? You simply have to put your hand on the patient's abdomen, find the uterine fundus, and begin massaging the fundus in a circular motion, compressing the uterus downwards towards the vagina. And as you're massaging, you observe for bleeding and the presence of clots. And with the constant massage, you should be able to see a decrease in the bleeding and a contraction of the uterus should be palpable. As one provider is providing uterine massage, somebody else, another member of the team, can place 1 or 2 large bore IV cannulas. These cannulas can be used for IV fluids, for IV medications, and even a potential blood transfusion if required. When placing the IV fluids, it is always a good idea to draw blood at the same time to send for cross-match and for other investigations as may be required, such as hemoglobin or a clotting time, bleeding time. Now, the question is, how much of fluid do you give to a hemorrhaging woman? If your patient is actively hemorrhaging, if the hemorrhage is not controlled by uterine massage alone, it is generally recommended to give only a 300 to 500 cc bolus of crystalloids, which is normal saline or ringer lactate, and repeat it only to keep the systolic blood pressure above 70 until you have been able to control the hemorrhage completely. At this stage, our aim should not be to elevate the blood pressure because injudicious administration of IV fluids will lead to a dilution of the clotting factors and will cause further deterioration of our patient. Next step, uterotonic medications, very, very important. We all know the names of these medications, but the point to be remembered is that when these medications are given as a part of management of postpartum hemorrhage, the dose is different from what was given for prevention of postpartum hemorrhage. In a setup where no uterotonic medications are available, if an intrauterine balloon tamponade is available and if there is facility for insertion, this would be the time to insert a uterine balloon tamponade. Otherwise, preferably one by one, we start giving our uterotonic medications. Oxytocin is generally considered universally as the first-line medication, but if IV oxytocin is not effective at stopping postpartum hemorrhage, another medication can be indicated. So for treatment doses, oxytocin is generally started at 20 to 40 units per liter at 40 to 60 drops per minute. However, if bleeding is not arrested by oxytocin alone, the second-line drug will depend on the experience of the providers, on the availability of the drugs, and the known indications or contraindications of the patient. Most commonly used second-line drug in our setting will be misoprostol, given 800 micrograms. Now, WHO recommends that misoprostol be given sublingually, but it can also be given rectally if your patient is unresponsive and if you do not want to give a sublingual administration. Most common side effects with misoprostol will include shivering and a fever, but the biggest advantage in our scenario is that it does not require refrigeration. Another very commonly administered drug is ergometrine or methyl ergometrine, given 0.2 mg intramuscular. This can be repeated every 2 to 4 hours with a maximum of 5 doses up to 1 milligram over 24 hours. However, this comes with a severe limitation. It has to be given only if you have excluded hypertensive disorders in your patient, and it has to be used with caution in women with cardiac disease and women with severe anemia with hemoglobin of 2, 3, or 4 grams. Other drugs could include carboprostol, which is PGF2 alpha, given 0.25 mg every 15 minutes or so, up to a maximum dose of 2 milligrams. This again is contraindicated in women with asthma and has severe side effects of nausea, vomiting, and diarrhea in some women. Another drug available in the Indian market is sometimes symptometrine, which is a combination of oxytocin 5 units and ergometrine 0.5 milligrams. But it is also recommended only where hypertensive disorders can be excluded. The next thing to be done as a part of first response bundle is a tranexamic acid. It is only to be given if PPH occurs within the first 3 hours of birth. I think all obstetricians here would have heard of the women trial and its findings that showed almost a 31% reduction in maternal mortality from postpartum hemorrhage simply by timely administration of tranexamic acid. How is it different from all the rest of the medications and why does it deserve a special slide of its own? Simply because it is not a uterotonic in that it does not contract the uterus. Instead, tranexamic acid works to slow the breakdown of blood clots, which will help to stop the postpartum hemorrhage. How is it given? It is given 1 grams in 10 ml, which is 100 milligrams per ml IV at 1 milliliter per minute. Therefore, it has to be a very slow IV injection, almost taking 10 minutes for the full dose. And then the patient has to be observed. If bleeding has not stopped even after 30 minutes of the first dose, it can be repeated in the exact dose. This drug also comes with its contraindications. It is not to be given in the presence of active thrombotic disease, that is pulmonary embolism, deep vein thrombosis, also to be avoided in women with a strong history of thrombotic disease. So these were the part of the first response bundle. These bundles by themselves are to be used for each woman with PPH, but are independently not enough to arrest hemorrhage in most of our cases, which is why we move on to the supportive measures. The bundles are focused on PPH from atony only. However, these additional measures are essential clinical interventions beyond the bundles, which are part of the PPH evaluation and which help us identify and treat other causes of PPH. These are called as the supportive measures of the first response bundle. Going through them one by one. First would be to check for tears and repairs. Even if you have checked for tears once the woman was born, if you detect an active hemorrhage, go back again and check again. You might just have missed something that you will detect now. Cervical and vaginal tears often cause very brisk bleeding, and it may be difficult to examine, especially with pooling of blood in the vagina. Ensure that you have adequate light, a good exposure, and that you have good instruments available for your examination. As ma'am said, it's a good idea to have a special tray be made for this purpose. Separately use ring forceps or sponge holding forceps to examine the cervix in a way that you can examine the entire circumference of the vagina and cervix. However, there may be some cases where the bleeding is so much that you are unable to see anything. Even as you put your instruments inside, everything is good, light is good, but still there is so poor visibility because of the pooling of blood. In these cases, it can be a good idea to place an intrauterine balloon or to try an aortic compression to decrease the blood flow coming out of the uterus to facilitate the local examination of cervix and vagina. Dr. Bangal will be covering these in his talk. Another thing that we can find is a cervical tear. Ma'am has already talked about the management of cervical tear. Again, the only thing that I want to reiterate here is always make sure that you have reached the apex of the tear and that there is no extension of the tear going into the lower uterine segment. However, if you cannot immediately stop the bleeding from a tear for whatever reason, the steps to be done are apply pressure on the bleeding points to decrease the blood flow, get help from somebody who is more experienced than you, who can stop the bleeding by applying sutures, or if at your facility there is nobody available of the kind, then she will need transferring. Ensure that the patient's initial resuscitation has been done before you transfer the patient. We need that the bleeding is controlled as much as possible. You have wide bore IV cannulas in place and the patient's vitals are stable. Also, a good idea to empty the bladder. Even if the patient had voided urine after delivery, it is a good idea to empty the bladder after a diagnosis of PPH is made. Foley's catheter is only to be used in cases of rapid hemorrhage or if the patient is unable to get up and void or has developed hemodynamic instability and needs urine output monitoring. Next step would be to empty the uterus of all the clots that could be present, as these clots will inhibit the uterus from contracting completely. The procedure to do is you obtain an informed consent, administer analgesia if possible, wear long sterile gloves. With one hand, you go over the fundus. With the second hand, you go gradually into the uterus, gently remove any organized clots while constantly giving gentle massage over the uterus, ensuring that the uterus is contracting as your hand is placed inside and gradually come out. However, if there is a piece of placenta that you find is adherent, do not try to forcefully remove it. Abandon procedure, transfer to the operation theater for further management. With this, we come to an end of the first response bundle. Now, at this stage, we will again assessing our patient to evaluate if her bleeding has been arrested by these measures or if further actions and interventions are required. Most hemorrhage is arrested by the first response bundles and the supporting measures. However, for some women, refractory measures may need to be taken, which Dr. Bangal will be talking about in greater detail. I thank you all for your patient hearing. Thank you.
Thank you so much, ma'am. So with that, we're now moving on to a small break of 5 minutes. We request you all to get a good stretch or grab a cup of coffee and return back to your screens in another 5 minutes. We'll begin again in another 5 minutes. Okay, so the break is over and I hope all our participants have returned to their screens now. For the next session, I would like to invite Dr. Vidyadhar Bangal sir. Sir is Professor and HOD at Department of Obs-Gynae at Rural Medical College, Pravara Institute of Medical Sciences, Ahmednagar, Maharashtra. He has over 30 years of teaching experience and is a postgraduate teacher and examiner and a PhD guide. Sir has membership of many professional bodies such as FOXI, ICOG, IMA, and IPH. Sir is also co-chairman at Board of Studies Reproductive and Child Health at PIMS. He is also president at Loni Obstetrics and Gynecological Society and an editorial board member for 4 international journals and peer reviewer for 6 international journals. Sir also has 153 research publications in index journals, and his areas of special interest are obstetric emergencies, high-risk pregnancy, community obstetrics, medical education technology. We welcome you, sir, to talk about response to refractory PPH and supportive measures.
Thanks, Dr. Ashna, for a kind introduction. The topic, am I audible?
Yes, you're audible, sir.
Yeah, the topic given to
Please
me
put your
is
slides on slideshow. Yes. Great.
Is it visible?
Yes, it's visible now, sir.
Yeah. Thank you very much. Topic given to me is response to refractory PPH and what supportive measures have to be done to in this particular situation. Dr. Preeti has already talked about the first response bundle that is required to be done in the management of PPH. So I will be specifically talking subsequently what needs to be done once the PPH is not controlled with whatever measures that have been narrated and explained in the first response bundle. I'm working in the Pravara Institute of Medical Sciences since last 30 years. And this is a hospital where I am actually presently serving. So this is the slide which we are trying to show during every presentation. And this is what we call it as a PPH bundle card. The thing which I'm showing and I'm supposed to present is this component, that is refractory PPH interventions. These are the 3 refractory PPH interventions which needs to be done. And similar to what some supportive measures are there in the first response bundle, similarly, there are 3 more supportive measures which are expected to be done or taken in the refractory PPH intervention. So I will go one by one and then till I finish with this surgical part of management of PPH. So these are the 3 supportive measures. Now, there has to be some trigger to call it as a, or for a need to go to a, or label it as a refractory PPH. The trigger for the response to refractory PPH bundle is bleeding that does not stop as part of first response bundle, which Dr. Preeti has very well highlighted, and all those components she has narrated which needs to be taken to manage the PPH at first go. But even after doing those management steps, if we are unable to control the PPH, we call it as a refractory PPH. And then the situation, you can all know that when the patient has continued to bleed and her vitals have started deteriorating, the panic situation also arises unless we are very well prepared to manage that. And during this phase, when we label it as a refractory PPH, it is very essential that we continue to give the treatment that has been mentioned in the first response bundle. That includes continued IV fluid administration. We can here give second dose of tranexamic acid since patient has continued to bleed, and we should continue also oxytocin infusion. So IV fluid will continue, second dose of tranexamic acid will go, and oxytocin drip will also continue. Now, considering that she's bleeding and her vitals have started deteriorating, and we foresee what complications might arise, accordingly, we must start thinking beforehand and ask our ancillary staff to either alert the blood bank or need for or call for additional help. It could be, we all know now, it is likely that we may have to go for surgical management. So anesthesia and operation room staff must be informed that such and such case is being managed in the labor room, and we need to prepare even for transfer. If the patient is at a lower level facility, the things must start in the line of transfer of the case, or maybe even at the district hospital, or maybe in the labor room, a patient needs to be transferred to operation theater. So all these things should start once we label it as a refractory PPH. So what are those steps? The steps are compression maneuvers, intrauterine balloon tamponade, non-pneumatic anti-shock garment. Now all these three important steps which need to be taken, we will be, after this session, there will be a demonstration session, and all these maneuvers will be demonstrated either through video or maybe live demonstration. So I won't be going into details of these procedures, but at the same time, I will try to cover them one by one. In the first response bundle, there is no specific order, and multiple steps, actions can and should be done at the same time, which Dr. Preeti told you. However, you can see in this bundle, there has to be some order to think. In the refractory PPH bundle, we have to give this or administer this or take the steps in certain order. For example, first thing which needs to be done is immediately attempt compression maneuvers, second being intrauterine balloon tamponade, and then apply non-pneumatic anti-shock garment. So there is some order which is not there in the first response bundle. As Preeti said, all the components must be done in all the patients, whereas when it is a refractory PPH, it may not be necessary to do all the components, but if patient is bleeding, then of course all three components must be done as quickly as possible. Both compressive maneuvers and the use of non-pneumatic anti-shock garment are recommended as temporizing measures until substantive help is available according to WHO 2012 guidelines. Uterine balloon tamponade, which again we will be demonstrating you, may be a definitive treatment in many patients as it has a tamponade effect and controls atonic postpartum hemorrhage. In other cases, it may serve as a temporizing measure to control bleeding during transport or while preparing for surgery. So we can buy time by doing this uterine balloon tamponade or by applying NSG when patient is to be shifted from one place to another. Coming to compression maneuvers, there are two compression maneuvers which needs to be done, which can be done. It is a choice of the obstetrician or the attending physician to decide which needs to be done. And on the upper part of this figure, we have shown these are the two maneuvers. It's a abdominal aortic compression, and below is a bimanual uterine compression. So the diagrams are quite self-explanatory. Exact how it is to be done will be shown subsequently. Compression maneuvers, the intent of these compression maneuvers is to decrease blood loss in severe and rapid postpartum hemorrhage by quickly applying pressure. This is usually done temporarily to decrease blood loss when bleeding is brisk and can be used while IV medications are prepared and administered, or while the UBT or NIG is prepared for further management. Which compression maneuver is to be done? That is choice of the obstetrician who is attending. Bimanual compression, this is the first uterine bimanual compression. The useful when uterus has just been emptied bimanually with the provider's hand already in place to do the compression. There is one disadvantage of this bimanual compression, and that is uterine balloon tamponade cannot be placed when our hand is there in the vagina and which is trying to compress the uterus bimanually. So this is one of the disadvantages of performing this. But of course, when the UBT is not been planned, immediately whenever there is a bleeding, we must go ahead with the bimanual compression. Exact steps I won't tell you at this point because they will be shown by Dr. Poonam subsequently in the demonstration. So I will skip with that. Abdominal aortic compression. We all know that the pelvic blood supplies through the aorta, which divides into two common iliac arteries, and subsequently whatever blood loss is from the pelvic vessels can be controlled by abdominal aortic compression. Again, we will be demonstrating you exact procedure, how it is to be done. So I won't go into details. There is a good video which Dr. Preeti will be showing on how exactly aortic compression is to be given so that bleeding immediately gets arrested, as we are totally cutting the pelvic blood supply off and bleeding is immediately controlled. So it is a mechanical compression of the aorta that can also temporarily slow down blood loss while we are planning for a definitive. If the patient starts bleeding in the labor room or maybe in operation theater during cesarean section, and we are not prepared for that, it is better that immediately we can go for aortic compression till additional help is available. So this is extremely important step that every obstetrician must know how to do it, and in such situation, it will definitely be a life-saving procedure. Then other than compression maneuvers, there are two more things which are components of refractory PPH management. One of them is uterine balloon tamponade, which is shown in the first figure, and second one picture, there is a garment called anti-shock garment. Since there is no air in that, it is called as a non-pneumatic anti-shock garment. It is put around the patient's lower half of the body. There are multiple segments, and this will help in taking the blood away from the non-vital organs, and it will push towards the vital organs. Details I will let you know soon. So first, coming to uterine balloon tamponade, again details will be shown in the demonstration. Uterine balloon tamponade is indicated in patients with acute postpartum bleeding for whom uterotonics are ineffective. That's why we are calling it as a refractory PPH now. And there are various types of uterine balloon tamponade. Dr. Poonam will show you one tamponade which we are using, that is called ESM UBT kit. That is every second matters uterine balloon tamponade kit. So she will be, it is very well tested, studied, and it's made available by Government of India, and it will be demonstrated to you soon. Uterine balloon is placed into the uterus of the bleeding mother and inflated with water. The balloon presses on the bleeding vessels inside the uterus and the bleeding gets controlled. Secondly, non-pneumatic anti-shock garment, NASG, and it is a non-pneumatic, this is a low technology, life-saving first aid device made up of neoprene and Velcro, which is used on women and obstetric hemorrhage. It is a reusable garment, and it helps in bringing patient out of the shock or preventing patient going into the shock. So it's just a simple garment. It is origin is in the United States of America. That time it was used to be called as a pneumatic anti-shock garment, which they used in war for saving the lives of the soldiers as war victims. And then this is modified and being used now in the management of all shocks, including obstetric hemorrhagic shock. It decreases the blood flow to the lower body and shunts blood to the vital organs, as I immediately said before. Now this is a principle which is being shown, that the physiological principle, the blood, whenever there is a bleeding from the uterus, in the lower diagram you see that when the garment is applied, the blood, whatever is available into the circulation, will push into the upper part of the body where the vital organs are there. So whenever there is a decompensatory shock, NASG decreases blood loss and reverses the shock. So this is what is the physiological principle. There are many conditions, not only the postpartum hemorrhage, but wherever there is excessive hemorrhage of obstetric origin, like ectopic pregnancy, abruption, placenta previa, or atonic postpartum hemorrhage, this garment can be used. It's not only the, as Preeti said, that we have not to wait for the shock to develop. We have to anticipate that patient is deteriorating. She is not responding to our first response bundle. Immediately we should start taking steps towards the further management. There could be other signs of shock developing by that time with the tachypnea, tachycardia, patient becoming pale and cold clammy skin, urine output is decreased, patient shows signs of hypoxic encephalopathy. This is the time when all these measures like UBT and NAG should be used. This is how it is applied, and our nurses are being trained. This is how it is properly correct application of NASG. There are segments 1 and 2 for the lower limb, 1 near the ankle, 2 near the calf muscles, segment number 3 around the thighs, segment number 4 around the pelvic part, and segment number 5 and 6 in the umbilical region. Sometimes in a hurry, it is not properly applied, and this is one example where it is not being properly applied. If it is properly applied, then only it will be useful and effective. That's why the training is not very difficult. Anybody can apply, but they have to be properly trained so that it is effective when applied. At my place, now the practitioners also send the patients with NASG. This is one of the case which has come to the casualty, and we have shifted it on the stretcher with NASG. This is the patient shifted to operation theater with NASG. Now this is a case of PPH with NASG and UBT in place, which this blue catheter you say it's UBT. Subsequently, patients are going to recovery room with NASG on place, and once the patient is stabilized, NASG is removed one by one. How to remove the NASG? It has to be, there are, as I said, 6 segments or maybe 5 segments. Each segment has to be removed with an interval of 15 minutes. Segment removal starts from the ankle. Segment number 1 is removed. Then after 15 minutes, after taking pulse and blood pressure, we remove segment number 2 and subsequently 3, 4, 5, and 6. So within 1 or 1.5 hours, all segments can be removed. We have to see that the IV is running when we are removing the segments. And of course, vitals must be monitored. If patient shows signs of deterioration, again starts bleeding, there is tachycardia or hypotension, immediately all segments must be reapplied. This is a reusable and washable garment, and it is to be used, it is to be washed or maybe kept in contact with the 0.01% of the sodium hypochlorite, 10 to 20 minutes contact, then washed, dried, and again kept back at a proper place for its reuse at the subsequent emergency. UBT stops bleeding but does not treat shock. At the same time, NAG is designed to treat shock but not to directly treat bleeding. In the response to refractory bleeding bundle, both devices will be used in patients who are actively bleeding and in shock. So these are the 3 things which I have said about the refractory PPH intervention: compression, uterine balloon, and anti-shock garment. Other 2 supportive measures are blood transfusion. When a patient has started bleeding and pallor is increasing, we must see the signs of blood loss, and accordingly we must start arranging blood. If the blood is not available of the particular group, 2 to 4 units of O negative packed red blood cells can be administered as early as possible. If we are working at a lower level facility, we must arrange for transfer to a higher level of care by arranging the appropriate transport. And we must see that during transport, patient is stabilized. All our measures, whether it's a first response bundle or second response bundle, they must continue during transport so that patient reaches safely to a tertiary care center. Transfer is required whenever adequate treatment, monitoring, and resuscitation is not available at the initial facility. Coming to the last component, that is surgical management of postpartum hemorrhage, majority of the things have been covered. A wide range of surgical interventions have been reported to control PPH that is unresponsive to medical and mechanical interventions. Now, indications for surgical treatment are uterine atony, which is not responding to our measures, soft tissue injuries, which have been covered, or retained placenta or placental tissue that will again be covered in the subsequent talk. These are the causes of PPH, which have been covered by Madam Archana. Cervical tears by suturing, colporexis by exploration suturing, broad ligament hematoma exploration, and all these have been covered because these are traumatic causes of PPH. Surgical options for managing retained placenta by MRP, surgical evacuation of uterus, and last resort, obstetric hysterectomy. There are certain compressive sutures which can be given to the uterus In atonic uterus, they are B-Lynch, Heman, and Cho. So one of the sutures Dr. Preeti will be demonstrating, that is B-Lynch suture. I won't go into details because these are being covered in the demonstration. This is the diagram which shows B-Lynch suture. It's a buttressing suture that compresses uterus and controls bleeding. Heman suture is another suture similar to B-Lynch suture. There is another called a Cho suture where multiple sutures are given onto the uterus, but the complication rate is more with these Cho sutures. Overall, it is said that when they are immediately applied and properly applied, these sutures can arrest bleeding in 76 to 100% of the cases. And definitely the surgical intervention like obstetric hysterectomy, chances are the requirement is less if we apply these compression sutures. There is enough evidence in support of these compression sutures. And if the uterine atony is not being controlled, then we may have to ligate the pelvic vessels. They are uterine artery, ovarian or uterine artery ligation anastomosis, and of course internal iliac artery ligation. We must know the anatomy of these two vessels, and there is some correct way and incorrect way of putting the mixture forceps. The mixture forceps should ideally be put from lateral to medial. If we put it from medial to lateral, there are more chances of injury to the internal iliac vein. So mixture forceps, of course, this requires a lot of technical expertise, and only those who are aware about these final aspects of this surgery, it should not be attempted. Internal iliac artery ligation, as I said, it has likely complications like injury to the veins. It could may cause injury to the artery itself, or maybe external iliac artery or internal iliac artery, or accidentally there can be ligation or crushing of the ureters. Obstetric hysterectomy, overall attempt is being made in PPH bundle method so that the surgical intervention should be reduced, especially the obstetric hysterectomy necessity is reduced if we completely and properly use PPH bundle approach in the management of PPH. So obstetric hysterectomy should be reserved only for few cases, and it should not be done as the first resort when the medical management fails. Unfortunately, there are reasons we lose patients even after surgical interventions, and even today, these are some of the reasons. There is a delay in hospitalization, there is a high shock index at admission, delay in performing surgery. Surgery is performed, but it is not appropriate. There is scarcity of blood or lack of intensive care. There are multiple factors under each category. I won't go into details, but unfortunately, still these factors exist, and we lose mothers because of these reasons. For ensuring positive surgical outcome, the decision for treatment should be prompt. If at all it's a surgical treatment, senior should be physically available in the operation theater. Surgery should be correctly chosen. There should be effective communication between team members. There should be early replacement of the blood. We must use shock index as a parameter to assess the condition. Correct fluid management, critical care consultant availability makes a difference, which we saw in Cali, Colombia when I visited with Poonam. Youth checklist in OT and debriefing sessions will see to it that such mishaps, or maybe there would be improvement in our overall care of the patient if debriefing sessions are conducted. To end, I will say as a take-home message, in situations where medical management has failed to control the bleeding, a prompt decision should be taken for mechanical intervention and, if need be, surgical interventions to save life. With so many women dying each year globally, we should work hard at all levels to save every mother and reduce maternal mortality. These are some of the references for my presentation. I sincerely thank and acknowledge the knowledge sharing and the support which we received, and I personally received from MGH Boston, from Cali, Colombia, and of course my alma mater, and Poonam from MJMS Sevagram, India. Thank you very much for patient sharing.
Thanks a lot for that elaborate explanation, sir. We are now moving on to the video and live demonstrations. And for that, we first have Dr. Suchi Jain, ma'am. Ma'am is Professor OBGY at MGIMS Wardha. She has done many quality improvement projects with NQCN and is also a member of the National Mentoring Group for Lakshya. She's also collaborated with ICMR, WHO, and Government of India, Harvard University, and NIE for projects in maternal health improvement. She's also done a fellowship in endoscopy And ma'am has over 30 publications in national and international index journals, and her special interest includes high-risk obstetrics. So ma'am will be demonstrating live about the bimanual uterine compressions.
A very good afternoon to one and all present today. We move on to the skill demonstration sessions, and the very first skill demonstration is on compression. So we'll be dealing with bimanual compression. As you can see that Dr. Bangal talked about PPH emergency response, and in this, when you see the card for the refractory PPH interventions, one of the measures which can be done if the patient is not responding to primary measure is that you can go in for compression. This compression could be either bimanual or it could be aortic. So we'll start with the bimanual compression. I'll be reading the checklist, and my postgraduate second year, Dr. Mihir Ranade, will demonstrate the procedure to you. This checklist can also be used during training and actual patient scenarios so that you don't miss on anything. So going with the principles of respectful maternity care, we have to tell the patient what we are going to do, listen to her, respond attentively to her questions and concerns, provide her continuous emotional support and reassurance as feasible, put on personal protective equipment as Dr. Mihir has already put it on, use an antiseptic hand rub or wash hands thoroughly with soap, put high-level disinfectant or sterile surgical cloths, and we have cleaned the vulva and perineum with antiseptic solution. The first step, as I read according to the checklist, he will insert one hand into the vagina and form a fist. So he forms a fist first, and then he inserts the hand into the vagina. You place the fist is to be placed into the anterior vaginal fornix and apply pressure against the anterior wall of the uterus, which he is showing to you right now. So he's put his fist in the anterior fornix and he's applying pressure against the anterior wall of the uterus. Then he places the other hand on the abdomen behind the uterus. And you press the abdominal hand deeply into the abdomen and apply pressure against the posterior wall of the uterus. So the principle of pressure tamponade is used and compression is being done, and you maintain this compression until the bleeding is controlled and the uterus contracts. After that, once the bleeding is controlled and the uterus contracts, you can release your anterior hand from the vaginal fornix and your posterior hand from the posterior abdominal wall. At the same time, once you have removed them, you immerse both the gloved hands in 0.5% chlorine solution and use an antiseptic hand rub or wash hands thoroughly with soap, and then monitor the patient for vaginal bleeding, taking the woman's vital signs every 15 minutes for 1 hour and then every 30 minutes for 2 hours, and make sure that the uterus is firmly contracted. In case this is not happening, you can go in for simultaneous aortic compression. In the meantime, the UBT can be kept ready, NASG can be used, and so we will go through this procedures one by one. So Dr. Preeti will now show you a video on aortic compression. Thank you.
Thank you, ma'am. We now have a video demonstration on aortic compression.
The first thing is to stop the bleeding. And we're now going to demonstrate one method by which you can stop almost all life-threatening bleedings from the uterus. And therefore we're going to do the bimanual compression of the abdominal aorta. This is an external compression. It has nothing to do with the bimanual uterine compression, which is less important to use, but you should use the external one while another one is preparing the vagina for the tamponade technique. So the first thing to consider when you make the compression of the abdominal aorta is to remember the anatomy of the aorta. At the umbilical level, we have the branch of the common iliac artery on the right side, on the left side. And from each of the sides, we have the internal iliac artery branching to the uterine artery. You must check if this woman in shock or close to shock has any pulsation in the inguinal area. And then we put our 4 fingers parallel with the inguinal ligament. And very often these women having bled excessively with a very weak pulse. The fist should be closed with the thumb outside, not inside, because then you have a very strange configuration of the fist. The thumb should be outside in order to create the right 90-degree angle between the metacarpal bones and the digital bones, the first one. So we use that as an instrument by which we can approach the bifurcation and have the arm perpendicular to the umbilicus. So by putting my closed fist like that, very softly, I can go down. Now I feel the aorta, the pulsation. You can see my elbow and I can see my hand going up according to the pulsations of the aorta. Now I go a bit further and down. Now I can no longer feel the pulsation in the inguinal area, which means that every circulation from this level is stopped and vagina is basically bloodless. I can ask an assistant to go into the vagina, to put the tamponade and fill the tamponade to stop the bleeding. And when the tamponade is there, I can lift my fist to see that everything is all right, there is no bleeding down there. Something which is very important here is to really check the femoral pulse and not to rush to put the fist there, because you don't know if you are really blocking or not blocking the aorta. So that is the controlling hand, so therefore we call it a bimanual maneuver. We have nothing in the vagina, we are not compressing the uterus, but we are pressing on the aorta and we are checking in the inguinal area.
Okay, so for the next video, since Poonam ma'am will be back in another 5 minutes, we'll first see about methods of uterine balloon tamponade by Dr. V.B. Bangal sir.
Hello. Today I am going to demonstrate the use of NASG to all the audience. For this demonstration purpose, I have my postgraduate students Rutuja, Purna, Shweta, another Shweta with me. They will help us in making this demonstration possible. Okay. So to begin with, which we keep it after the use in a fold position, and whenever we are keeping this NASG at various locations like labor room, intensive care unit, operation theatre or casualty, it should be kept in this folded position so that it will have a smaller volume. And one more important thing is everyone in these areas who are working there must be knowing what is the location of this particular NASG. So as you know that NASG, as I said before, it is used in an emergency situation. So in an emergency situation, everyone must know where is the location so that suddenly whenever emergency arises, this is available to us for immediate use without wasting much time, since the time is very, very crucial. So this is the folded form of NASG which Rutuja is holding, and now we will just unfold. This is a Velcro action to this, and this is how we unfold the NASG. This is a single garment. This is how it looks. Now after unfolding of this NASG, how it looks, this is the external side of this NASG. These dots are shown as it is going to be in contact with the spine of the patient. Okay, it has multiple segments. Here you see the segment number 1 from below, from ankle side, 1, 2 and 3, they are paired segments. Then there is a single segment of segment number 4. There is a partial segment that is called segment number 5, and then there is a segment, again single segment, that is segment number 6. there is a ball in this segment number. This is a pressure ball which is placed over the navel and it is written there. So this is how the NASG looks like after unfolding. So we'll just keep it aside. Now looking at the, this is the unfolded NASG which is I have kept, and these are the segments which are written. As I said, segment number 1, 2 and 3 are paired segments. Segment number 4, 5 and 6, they are single segments. Segment number, out of these 3, segment 5 is not a complete segment, it is a partial segment and it comes on the patient's navel when we apply it. So we'll just demonstrate how this NASG is to be applied. I request Shweta to be sort of, she will be mimicking a patient. Now please lie down. Yeah. So patient could be conscious, patient could be unconscious. As I have said, this NASG is used. NASG is used in a condition of shock, where patient may be conscious, may not be conscious. So depending upon the level of consciousness, we have to apply this NASG. Now segment number 1, 2 and 3, they are for lower limbs on each side. Segment number 4, we call it as a pelvic segment that comes over the pelvic region. Segment number 5 comes on the umbilical region, and that is post-delivery. It will be having additional pressure on the sort of a postpartum uterus, so that it will have cause compression of the uterus and maybe further help in contraction and reduce the bleeding. And over that segment number 5, we have segment number 6, which also will come into the over the segment number 5. So whenever we put this garment, if the patient is conscious, then while putting from below, we can just ask the patient to lift her leg and then we put it. Both the limbs, we can ask her to lift her this much pelvic portion and put it. So from below we can just slide it upwards. If the patient is unconscious, then we put the garment, unfolded garment on one side, turn the patient to another side and vice versa, so that the garment comes exactly underneath the patient. Now one important thing has to be kept in mind. The upper border of this garment, that is upper border of this garment, should be at the subcostal margin. In other words, the garment, the upper portion of the garment should not cover the chest region, because after application it should not cause any difficulty in breathing for the patient. That's why that thing has to be kept in mind while putting the garment under the patient. So segments I have explained. Now if we have sufficient people to help us in an emergency, then one person can be on one side, another person can be on the other side, and they will start applying this garment simultaneously in order to save the time. So this is the segment number 1, segment number 2 and segment number 3. Okay, so I will ask, and this is the segment number 1 is around the ankle, and this is a neoprene garment and there is a velcro action to this particular garment. So whenever it is applied, the non-velcro portion is lifted first over the extremity, and then velcro segment is tightly applied over this particular lower portion of the leg. So like this, if there are 2 people simultaneously, we can apply segment number 1. So now I will ask them to apply segment number 2, and this it has to be properly lifted and it should be tightly applied. Whenever we apply the segment, we have to see that whether it is tight or not, and by putting a finger underneath the garment and releasing it, there will be a sort of a snap like sound. And a good snap sound will indicate that it is properly applied. If it is a loose, then it is not going to be of any use. Then segment number 3 will come. Segment number 2 is around the calf muscle. Segment number 3 is over the thighs. Again, we stretch one portion, apply third, and then again check for the snap. Here one thing has to be kept in mind. Ideally, the knee portion has to be free. The knee should not be covered because there is some reason why the knee should be kept. Because with this position, whenever patient is in shock and if this patient is going to for any surgery, we should be able to give lithotomy position. If this garment is covering the knee, it would be difficult to give the lithotomy position. That's why while applying, the person should see to it that the knees are kept free and not, there is no garment over this. So segment number 4 is now pelvic segment. Now as I said, pelvic segment number 4 and 5 should be applied by single person because it's then only we will come to know how much is the pressure. So I will ask Shweta to apply segment number 4. Again, we apply it, stretch it, and over the, it will not dislike the person. Okay, ये तो चालू है, edit करते हैं, ठीक है. So this is the segment number 4 has been applied. Now segment number 5. 5, as I said, there is a ball in this. So this will come over the navel of the patient, and over the segment number 5, this segment number 6, this is segment number 6, it is to be applied. So again we have to see that it should not be very tightly applied, and patient should be asked is she comfortable or not. If she says that she is uncomfortable, there is a difficulty in breathing, then it should be slightly loosened. So this is how we apply all these segment number 1, 2, 3. 1, 2, 3 can be applied simultaneously by 2 people in an emergency. Knee has to be kept open, preferably. Segment number 5, 4, 5 and 6, they are to be applied by single person, and the upper margin of the NASG should not cover the rib area, so it should be at the subcostal margin. So this is how we apply the NASG in a patient who is in shock, mainly in obstetric shock due to hemorrhage, commonest reason being postpartum hemorrhage. But it's not only postpartum hemorrhage, we have experience of applying it in all types of obstetric shock, mainly ectopic pregnancy coming with shock, or maybe post-accidental hemorrhage, vaginal delivery, there is because of the hemorrhage patient going to shock. So we are using this NASG in all types of obstetric shock, mainly hemorrhagic shock. So this is about the application of the NASG. Now once the patient is stable, then after 2 hours of the hemodynamic stability, we can start releasing or removing this NASG. There is no need once the patient is come out of danger. So while removing this NASG, we again start from the segment number 1, then segment number 2 and segment number 3. So slowly from below upwards we start removing this NASG. Now one thing has to be kept in mind, that both the segments have to be released simultaneously. We should not start removing the segment from above. There has to be an interval of 15 minutes between removal of these segments. So for example, if we remove, patient is stable, after 2 hours we plan to remove, segment number 1 is removed, we take the pulse and blood pressure of the patient. If she is found stable, then after 15 minutes we remove segment number 2. Again we repeat pulse, blood pressure, and if stable we can remove the segment number 3. So these segments must be released simultaneously. I will ask them to release the segment simultaneously. Segment number 1, and then after 15 minutes segment number 2, then segment number 3. Okay, and afterwards this segment number 4 and 5 can also be similarly removed. So this is how these segments are released after confirming that the hemodynamic stability is there. Ideally intravenous fluid, IV fluid should be running whenever we are removing this NASG, because if there is again either fall in blood pressure or rise in pulse rate, or patient starts bleeding again after removal, this segment should be immediately applied, and then we have to either find out why she is not responding to all this treatment, needs further evaluation. So this is how the segments are applied, segments are removed. Now once we remove the segment, we have to see that patient is stable and should be monitored for all her vital parameters including pulse, blood pressure, level of consciousness. uterine contractility, any pervaginal bleeding, and of course urine output, because we all know because of the shock there could be oliguria and patient may go into. So all these vitals must be monitored whenever patient, we use this NASG, and it has been found that when we use NASG in case of shock, the shock either patient, if she is in shock, the shock, she will come out of the shock. The principle I already told you, there is a shifting of the blood from non-vital area towards the vital organs like brain, heart, kidney, liver. So that will help in maintaining the circulation and function of the vital organs, and this is how this NASG helps. This is just a supplement. It is not a cause or it is not the treatment, but it is just a supplement to all our measures which we take in case of treatment of, in the management of shock. So it has been observed that this NASG is useful in bringing the patient out of the shock or reducing the morbidity due to shock, and that's why it is recommended that NASG should be there in all obstetric unit, all maternity hospitals wherever these deliveries are conducted, because we never know which patient will have go into postpartum hemorrhage and shock. So since it is a reusable, low technology, anybody can apply this with little training. So it should be there, and all the people who are working in the labor room area must be aware about the NASG, its use, how it is to be applied. So this is how I wanted to just show you the demonstration of this NASG. Remove these two segments. Now last thing I will like to demonstrate is how to fold. How to fold this NASG back to its normal again, how to fold it back and keep it back. So these are the segments. We put the Velcro segment first inside and then over it another segment. So all these Velcro segments are put inside so that it becomes a little more durable. Once these three segments are folded, then we segment number, there is a so these segments are folded. These three segments are then again put over this. Then we fold segment number 4 like this. This segment is put over this. These three segments. Then we put our segment number 5, and then lastly segment number 6 is put, and then this is how the NASG is again folded back and kept at a proper place for reuse. It's a multiple use we can do after cleaning. So if it need not be cleaned after every use. Okay, if it is soiled, if it is stained with the blood, then definitely it needs to be cleaned before every next use. And cleaning guidelines I already said in my presentation. It's dipped into the 0.01% hypochlorite solution. Contact period should be minimum 20 minutes, and afterwards this segment can be kept in the not directly into the sunlight, but it is dried. It can even be put into the washing machine, and it is said that if we properly use, this can be repeatedly used for 100 times in 100 patients of shock. So it is very much useful, and this is all about the NASG. I thank my team for helping me in this particular demonstration. Thank you very much.
So thank you, Bangal sir, for that wonderful demonstration on NASG application. For the next demonstration, I would like to invite Dr. Preeti Priyadarshini ma'am to demonstrate the B-Lynch procedure.
Thank you, Dr. Ashna. Before we move on to the B-Lynch procedure, I would like to just take a moment of your time to go back to the aortic compression procedure. We've already all seen the video. I just wanted to highlight once again that aortic compression is a method of mechanical compression of the aorta which is used to temporarily slow the blood loss and is useful even if the bleeding is not just from atonic but from other traumatic or other causes, because it directly cuts the blood supply going on to the lower segment of the body. It is very helpful if the patient is being transported from the labor room to the operation theater, or if the patient is being transported from one center to the other as a referral case. And patients generally tolerate it very well for a prolonged period of time. The video that was shared was made by Dr. Stefan Bergstrom of the Karolinska Institute, Sweden, and was used here with his permission. So moving on to the Belin sutures. Belin sutures also is a form of compression sutures that we commonly use in our operation theaters. It is used to mechanically compress an atonic uterus in the face of severe postpartum hemorrhage. Has been around for almost since 1997. Its importance lies in the fact that it is a fertility preserving surgery and has been described as the best form of surgical approach for controlling atonic PPH, as it helps in preserving the anatomical integrity of the uterus. Its advantage also lies in the fact that it can be performed after a cesarean or a vaginal delivery. If used after a vaginal delivery, the patient will need shifting to the OR. She will need a laparotomy and a lower abdominal incision. If used with a cesarean section, the uterus already has a lower segment uterine scar, and that can be used for the procedure. If the atony or bleeding was observed after the patient's uterine scar had been closed, the incision needs to be opened before proceeding further with the Belin sutures. So for description of the technique, once you have a uterine incision, the uterine cavity is evacuated, examined, swabbed out to see the amount of bleeding. Uterus will be exteriorized from the abdomen, rechecked to identify any bleeding points. Then before beginning the suture technique, first a bimanual uterine compression is tried to assess the potential chances of the success of a Belin suture if applied. If it is seen that the bleeding decreases substantially with the bimanual compression of the uterus, we proceed with the Belin suture. Generally, absorbable sutures are used as they can be left in situ and would typically not lead to problems with future pregnancies. Traditionally, a chromic catgut number 2 with a round body needle was used. A uterine incision is normally closed after applying the Belin suture. Now, Dr. Ashna, could you please play the video for us?
Yeah, sure, ma'am.
Thank you.
So this is the model that we are going to use to demonstrate our compression sutures or Belin sutures. As you can see, this is a huge model of a atonic postpartum uterus, and we will be using this model today for our demonstration. We have already marked a few points, point A, B, on the posterior surface point C and D, and again on the anterior surface points E and F. These points are marked because we are going to be taking our bites consecutively as the points are marked. So for point A, it is to be taken approximately 3 centimeters below the suture line. Point B is to be taken approximately 3 centimeters above the suture line. On the posterior aspect, in the posterior uterine wall, point C will be directly opposite point B. Point D will be directly opposite point E, which means that C and D would almost fall in a straight line. And point E and F would be 3 centimeters above and below the suture line. So starting our sutures, here we are using chromic catgut, which is an absorbable suture. It is preferable to use absorbable sutures because these sutures are expected to decay in the body over time and should not be left in situ for long. So we start from point A, we take a huge bite of a through and through bite of the anterior uterine wall and try to come out at point B in one bite only. Once we are through, we now have to flip the uterus, go on to point C, take our next bite from point C to point D, which means going from here and coming out over here directly. As you see, we are already falling short of a thread because the uterus is very enlarged, very atonic. We again go back to our anterior aspect of the uterus. Now comes the role of the assistant. I will now call my assistant to apply compression on the uterus from the fundal side to decrease the size of the uterus as much as possible. The Assistant will hold the uterus in place, apply pressure so that I am able to use the same thread and take the last remaining suture from point E and onto point F. We apply more pressure, make the uterus as small as possible, and then when the uterus is no longer compressing, we will make our knots. And be done with it. As you can see, the uterus that was hugely enlarged is now correspondingly much smaller. Both the sutures are sitting on the uterine fundal edge in a way that they cannot slip over the edge. These sutures will be left in situ and will disintegrate over time.
So thank you so much, Dr. Preeti, for that demonstration. For the next live demonstration, we have Dr. Poonam Shivkumar ma'am, who will be demonstrating about the methods of UBT.
Can you see us?
Yeah, we can see you, ma'am.
Okay. So what we are going to tell you today is uterine balloon tamponade and how to apply that. As I already said that whenever you give UBT or you apply UBT, the first thing is that you should have done primary response. You should have ensured that you have given enough medical management, because that is the management of choice. Once you have done that, you have tried aortic compression, bimanual compression, and yet bleeding is going on, so you simultaneously insert uterine balloon tamponade. Now, to explain, the first thing is that do not think that this patient has been repeatedly examined, so you don't need to take infection prevention practices. You have to do that. Ensure that you wash your hand properly as has been told by 7 methods, and then after that you have to come this side. So you have to use all the PPE, you have to wear that. Once you have done that, then the first step is that you have to clean the vulva and the area where you are going to insert. So this is 3 swab method, where from up down, you first clean one labia, and then second time you clean other labia, and then from inside, which is open, you just very gently clean that area. So once you have done that with 3 swabs, then you have to insert UBT. Now for inserting UBT, you have first thing, which is a catheter. This is a very interesting catheter, which is silicone catheter. It is extremely tough. If you see, it does not need any, holding of the cervix or anything like that. Because cervix is open, it very easily goes inside. Now to explain this particular Foley's catheter, you can see the distal end. Now this end has got 2 openings. One opens in the balloon, and second opens when you put a condom over it and you tie that condom. So these are 2. How do you identify these 2? There is one particular opening where you have a wall, and this is a single channel wall. So this is the one where you will instill for condom, and this is the one where you will instill fluid for ballooning it. Now, this is on the proximal end, you have a balloon. As you have in Foley's catheter, you have a balloon. Now, this balloon is very interesting. Ideally, we are supposed to fill up 15 to 20 ml, but a very interesting thing is that number of times cervix is quite dilated. So this balloon, you can fill up even 80 ml and it does not burst. So this is about this balloon. Now we have one, this is the condom. Now this condom is a very high quality condom. This comes in the UBT kit. I'll explain you the UBT kit later. First see the components. And this balloon is placed on the proximal end, and it is slipped all over beyond the beyond the balloon, beyond the uterine balloon. It is slipped all over, and then a part of condom is, taken out. So you can see that we do not place the balloon totally snugly fitting to the Foley's catheter, but we keep a little part of it at the anterior end. So it is free. So that is the reason how it's not going to burst. So this is how you keep the balloon. Now there is medicated band. You're going to tie that medicated band, and it takes only 1 minute to prepare this. 1, 2, 3, 4, and 5. So now your balloon is ready. So this is the thing what you have to do. Now, you have a 60 cc syringe in this, in which you take the fluid. Once you have taken the fluid, what is to be done is, we are going to, in this you will not be able to see, so we are showing you in the bottle. Now let's say this is the cervical end. This is the cervical end. So let's see how he puts it in. So this does not need anything except that, like this, you have to hold, and you just have to ensure that the whole balloon goes inside the this one. A little air is there, just remove that. Yeah, go ahead. So now this balloon enters inside. So this has gone inside. Now you see, this is the 60 cc what we have taken, the total 60 cc of the fluid inside. Now once it goes inside, then what you have to do is hold it. Now here, this is where you have to inflate the balloon. So you just push this, and you can see that the balloon is inflating. Can you see inside that the balloon has inflated? See, the balloon has inflated inside. Now, if you try to pull it, it's not going to come out because it is inflated inside. Next thing is that you are going to take out this, and now you push it in the single valve channel, and you start pushing the fluid. So, gone. Another 60 cc, the syringe is ready by your assistant. He has kept it ready. Now again, you push it. And you see how condom is taking the shape of the uterus and trying to compress it. Another one. You can see it inflating. Now, there are few questions which are asked. Would you leave this hanging? No, you do not leave this hanging. Rather, you take this. This is a crux of successful UBT. This is nothing but, this is a holder. This is a catheter holder. So how you have to do? This catheter will be put this like this, you will put it, and then this will be kept on the medial aspect of thigh like this. It will be just stuck like this. So this catheter will not come out, and the many a times you do vaginal packing and all that to keep the catheter. You don't have to do all that. So this is how you insert balloon. Now there are few questions which you would like to know. How much fluid are we supposed to put in? How much fluid we are supposed to put in? So we are supposed to, there is no, the fluid has not been decided that, okay, you have to put 500, 600, 300. It all depends on the individual
think there has been some technical problem and Dr. Poonam has got disconnected. Just wait for a few seconds more.
So can you hear me?
Yes, we can hear you, ma'am.
Hello?
Yes, we can hear you, ma'am.
Yes, ma'am.
Okay.
We can.
So I was just at the end of my this thing, the net went off here. So I have told you how much to fill. The question is how long can you keep UBT? So we can keep UBT, maximum recommended is 24 hours. People have kept it for 12 hours, 6 hours, depending on how the patient has been, but maximum 24 hours has been recommended by MGH. Third thing is that when do you remove it? So as you see that bleeding has stopped, 6 hours have passed and the coagulation mechanism have come in, you start removing 50-50 cc. Do not try to remove everything together. So 50 cc an hour after 50 cc an hour after 50 cc. And if you find that bleeding has started again, then you can refill it and keep it for another 12 hours or so. But if she starts bleeding heavily, that means it is not working and go ahead with your surgical management. So that is how you remove UBT. And then the last question many people ask is that how do you sterilize it? So nowadays, this is a kit which they are making. And this in this kit, if you see, this is a kit. In this kit, everything is available and this is ETO sterilized. This is being made by Government of India, HLN and Pregna. These are two companies who are making it. And this is a kit which contains catheter, 2 condoms, 2 medicated bands, the syringe, and then there is a folder kind of thing which tells you how to do the procedure. So it is a pictorial card which is there in which you can see and you can so even A&M can do this, and we have done this here in PHCs. A&Ms have put this and they have been able to do it. So this is how we have to go ahead with the UBT. So any questions, I would be happy to answer, or maybe later on whenever you have the question. Thank you so much.
Thank you so much, ma'am. We'll take all the questions at the end in the question and answer round.
Sure, sure.
So for the next session, I would like to again invite Dr. Shuchi Jain ma'am to talk about non-clinical components of PPH bundle, its importance in reducing maternal morbidity and mortality. So do we have Shuchi ma'am with us here? Okay, so I think they're trying to reconnect it. And we can then proceed to the next presentation by Dr. Reshmi CR ma'am. Ma'am is additional professor OBG at GMC Thrissur. She is also the scientific committee coordinator at TOGS. She is a national mentor for Lakshya at Nationwide Quality of Care Network. She is also a nodal officer for M&M Review at Kerala. She is a medical education unit member at GMC Thrissur and a member of Institutional Research Committee, editor of TOGS Journal for 2015 till 2017, and has presented many papers in national and state conferences. She is also a peer reviewer for JOGI and has publications and research papers in national and international journals and chapters in Foxy Focus, Why Mothers Die. And she has received many awards such as Gold Medal for Best Outgoing PG, 2002 GMC Calicut, and Chairman's Gold Medal Dakshin Quiz 2001. Her area of interest include quality improvement in healthcare and high-risk obstetrics. So we invite you, ma'am, to speak about management of retained placenta, placenta accreta spectrum, and acute inversion of uterus. Over to you, ma'am. Can you please unmute yourself?
Hear me?
Yeah, we can hear you now.
Yes. I'm sorry, I engaged in the theater. Can you please share the slide, or should I share it from my side?
Yeah, I'll share it for you, ma'am.
Okay.
Yes.
Okay. So our topic for today in this workshop, first of all, let me thank Bengal sir and NQCN for giving me this opportunity to present in front of such vast and august audience. So in continuation with all the complications of third stage, we will move on to the management of retained placenta and placenta accreta spectrum at acute inversion of uterus. Next slide. So third stage, as we all know, is very crucial and is very important in the management of and in maternal mortality and morbidity. Next slide. So retained placenta is said to be retained if it is not expelled from the uterus even after 30 minutes after the delivery of the baby. Next. So steps of expulsion, if you see that it is expelled in 3 stages. The first, it separates from the uterine muscle, then it descends into the lower segment of the uterus and vagina, and then it is expelled outside. Problem can occur at any of these stages, so we have to be on our toes till the placenta is expelled. So the risk factors, what causes the retained placenta? If there is a previous retained placenta, previous injury or surgery to the uterus, or in a preterm delivery, you have to be vigilant. Induced labor said to be an increased risk factor for retained placenta, and also multiparity. Next one. Placenta is separated but not expelled. That is one condition. It is already separated but doesn't move out. So, or it could be a simple adherent placenta, or it could be a morbid adherent of the placenta, placenta accreta, increta, and percreta. So, why placenta is retained. Here, the cause is failure of the woman. Sometimes the woman may be too exhausted, or the cervix is already closed, preventing the expulsion of the placenta, or there is a constriction ring found in the uterus. So in this case, actually, there is not much problem because the placenta is expelled. It has already separated and just it has to be expelled. Next one, please. So coming to simple adherent placenta. Here, the placenta may fail to separate completely from the uterine muscle due to uterine atonicity. There is a lack of contraction of uterine muscle. This happens in repeated pregnancies, grand multis, when there is a prolonged labor, or if the uterus is over-distended as in twin pregnancy. This is the commonest cause of retention of placenta. Next one. So what is morbid adhesion? The third level is the morbid adhesion of placenta, which fortunately is very rare, but if it occurs, it's a very serious problem we have to encounter. And here it is implanted deeply into the uterine muscle and fails to separate. In severe, it has many grades. It can burrow through the whole thickness of the muscle and come outside. Next one. So there are three types of morbid adhesion. Placenta accreta, where it penetrates deep into the uterine endometrium, reaches the muscle, but does not penetrate into the muscle. Placenta increta, where it attaches deeper into the uterine wall and penetrates into the uterine muscle. Percreta is something where it is attached. Actually, it is through and through, penetrates through the full thickness of the uterine muscle, but also attaches to another organ, the bladder or the rectum. Fortunately, as we all see, that placenta percreta is rare, but in our state, we are seeing more. I think it is throughout the world, it's the same. We are seeing more and more cases of placenta percreta, possibly due to increase in primary cesarean section rates. Next one. So what are the risks of retained placenta? What happens if the placenta is retained? The first and foremost is severe bleeding, which is life-threatening. And if you try to manually remove the placenta, you can have multiple injuries to the mother, vulvar hematoma, cervical tears. Next one. So even after 30 minutes, the placenta is undelivered. What should we do? First and foremost, please empty the bladder, catheterize. That itself may actually hasten the delivery of the placenta. Breastfeeding or nipple stimulation. Again, uterus will contract, the placenta will be separated. Even a change of position can be tried. Next one, please. So retained placenta, this you can do if there is no active bleeding. But if the placenta is retained with bleeding, what can we do? Immediately inform the OT team and the anesthetist and put in a large bore IV cannula, catheterize the uterus, start oxytocin, 20 units in 1 liter, 60 drops per minute. Then again, someone should be there, a scribe should be there to accurately measure and measure and also record the blood loss. And we have to go for a manual removal of placenta from the theater. Next one. So you can try for a controlled cord traction where steady traction on the umbilical cord can be made. This itself may remove the placenta, or we can go for MROP. Next one, please. So here, this is done under general anesthesia, all aseptic condition. Using a sterile glove hand is introduced in the uterus, and placenta is stripped from the uterine muscle gently and brought out. Next one. So this is how we do it. You have to support, be very gentle, and make sure you are the placenta is complete. And after that, give a uterotonic so that the uterus is contracted. Next one. So procedure, after the procedure, continue with oxytocin, observe the patient closely. Pulse BP should be monitored every 30 minutes. Palpate the uterine fundus for contracted uterus. Check for excessive bleeding, and if needed, blood transfusion also has to be given. Next one. So these are the complications. When you try to remove manually, forcefully, you can have uterine inversion, you can have shock, postpartum hemorrhage, puerperal sepsis. If a bit of placenta is there, there is an increased chance, and subinvolution of uterus. If the placenta is accreta, that is too deeply embedded, we may have to move on for hysterectomy. Next one. So this is the placenta accreta syndrome. It is abnormal placental implantation and firm adherence, which are classified according to the depth of invasion into the uterus into accreta, increta, and percreta. Next one. Can be as earlier madam has told, partial or total absence of the decidua basalis, and there is a defective development of Nitterbuch's membrane. So this is a FIGO grading of placenta accreta syndrome, grade 1. Grade 2 and 3 are some of the cotyledons are attached. 2 is entire placenta attached but not seen through the serosa. Whereas grade 4, 5 and 6 are the more severe varieties. Next slide please. So these are the risk factors: a previous history of uterine surgery, a placenta previa carries a 10% risk, previous cesarean itself is a risk. The more the number of cesarean previously done, more, and the risk factor is more. Multiparity, advanced maternal age, previous uterine artery embolization is said to be a risk factor. Endometrial thermal ablation, vigorous curettage during any procedure, and uterine pathologies like bicornuate uterus, submucous fibroids can all lead on or increase the risk of placenta accreta syndrome or the spectrum. Next one. So increasing number of cesarean sections. We all see that after 1980s, the number of cesarean sections have increased, and thus the placenta previa and accreta has also increased in throughout the world. Next one. So can it be prevented? Actually, we have to, whenever possible, we have to try prevention, prevent primary section, correct surgical technique while closing the uterine incision, encouraging trial of labor, treatment of postpartum endometritis, and also avoiding vigorous curettage. Next one, please. So how will you diagnose? Ideally, placenta accreta should be antenatally diagnosed. In placenta previa 20 weeks, there is a sensitivity of 96 to 98%. Even in the first trimester, if the gestational sac is low-lying, we can suspect. In second trimester also, loss of retroplacental sonolucent zone, diffuse or focal lacunar flow, vascular lakes, turbulent flow, all should make us suspicious that this could be a placenta accreta. Next one. And 3D power Doppler and MRI. But we have to remember, mind you, even with a normal MRI, even with an MRI report saying there is no previa or no accreta, we often have been surprised at the table with a accreta, placenta accreta syndrome. Next one, please. So how will you manage? Conservative management and obstetric hysterectomy are the two modes of management. Conservative management, we have to be always make sure that this is offered only for those desirous of preserving fertility. It has to be discussed earlier in the antenatal period itself. Next one, please. So conservative management, all this procedure aims in avoiding a peripartum hysterectomy. There is called an extirpative technique where manually you try to remove the placenta or leave the placenta. The second option is to leave the placenta in situ, cut the cord, give methotrexate in some cases. Then there is a one-step conservative surgery called just remove that accreta area and suture it. Then there is a triple P procedure where a suture is put around the accreta area after resection. Next slide, please. So these methods could be used alone or in combination with additional procedures like interventional radiology, uterine artery embolization, and tamponade techniques. Next one, please. So resort to conservative only if the patient wishes to preserve her fertility and when there is no active uterine bleeding, and also all the benefits and risks have been discussed and documented. Next one. Other options, methotrexate injection has been given. We have read it in textbooks, seen in literature, but it's not a routine. And uterine artery embolization, can we go for it? Can be offered in high resource setting, but it's not a routine according to RCOG. Next one, please. So this is obstetric hysterectomy. In severe degrees, always do a planned obstetric hysterectomy. Even a small area of placenta can cause torrential bleeding. So it could be done as a life-saving procedure. Next slide. So the main dictum in placenta accreta syndrome is anticipate and plan, have an early suspicion, diagnose it early, even at first or second trimester scan. Routine scan should be offered at 32 weeks for every pregnancy following cesarean to look for accreta. Confirm the accreta with MRI, early admission to hospital. Next one. And plan the surgery. Do not wait till 37 weeks and have a surprise in the middle of the night with a torrential bleeding. Plan the surgery at 34 to 36 weeks. In grade 2 and 3, we can consider partial resection. Grade 4, 5, and 6, go for a classical cesarean section, take out the baby, and then if it is accreta, depending on the grade, go for a hysterectomy. Usually what we do is we have a routine preoperative ureteric stenting of the patient, which will help us in identifying any bladder injuries and make the surgery a little more easier. And always keep blood and blood products enough ready. Team, who are the team? A senior obstetrician, an experienced anesthetist who is trained in critical care, a urologist, an interventional radiologist is well and good. If it is, if the person is available, can be we can take the service, but not in many places. An ICU trained nursing officer and also a blood transfusion specialist. So in effect, a multidisciplinary team is needed, and definitely this should be tackled in a tertiary care center. Next one. So what is the procedure? We have to go for a vertical abdominal incision. Uterine incision is usually done above the placenta. That is a classical cesarean section. And in Kerala, we have a different procedure where we apply the aorta. After delivering the baby by a classical cesarean, we apply an aorta clamp. There is a vascular clamp over the aorta or the common iliac, and then go for subtotal hysterectomy. And then after that, we remove the clamp and close with drain. Once, since introduction of this clamp, our blood transfusion requirement and also maternal morbidity has come down drastically. Next slide, please. So this is a specimen after a subtotal. Usually we may, a subtotal hysterectomy may be enough, but if the placenta is totally covering, we may have to go for a total hysterectomy. Next one. So this is our Kerala experience. We have started our confidential review of maternal death in 2004. At that time, before 2010, we used to encounter we used to see reports of 2 to 4 on-table deaths per year due to placenta accreta syndrome, and many were lot more we were having maternal near misses also. But after 2010, that is 2010 to 2020, 10 years, we saw only 14 deaths in the 10 years. But it is not as if the placenta percreta has come down. The number of placenta percreta has gone up. There were 76 near miss cases in the 2018, 1 year. I think it is 2018. So this change happened possibly. So we got to say more mothers. This was possibly due to we trained throughout Kerala, the staff nurses and the obstetricians were trained regarding emergency obstetric care, EMOCALS training, and also quality standards approach. And we introduced a common iliac and aortic clamp, which are used in most of the tertiary care centers, many of the medical colleges. Next slide, please. So there we have to anticipate uncontrolled bleeding while separating the bladder from the uterus and placenta. Why should we use the clamp? The solution is to control the blood flow to uterus and bladder before dissection. And we used to do internal iliac ligation, but many cases it was not found to be fully effective because the inferior epigastric artery from the external iliac artery develops collaterals with vessel in the bladder base and lower segment. Those of you have tried dealing with the placenta percreta and after internal iliac artery ligation also found torrential bleeding may know what I am saying. Next slide, please. So this is the common iliac clamp with smooth blades and gap between the blade of 2 millimeter. There is a long ratchet to regulate the compression pressure and it doesn't slip during operation. We apply it and put on a timer, and up to 30 minutes it can be applied safely. We have done this procedure, in most of the medical colleges in more than 100 cases. Next one. And now we come to that was just for the information, a new innovation, uterine inversion. So it is again an obstetric emergency, which is a life-threatening complication of third stage. Often it is due to mismanaged third stage. Inversion of uterus means uterus is turned inside out partially or completely. Next slide, please. So what are the types? It could be an incomplete inversion or a complete inversion where the inverted fundus is passed completely through the cervix to lie within or outside the vagina. Next one. Or we can classify it into first degree, second degree, and third degree, where first degree is just an inversion up to the cervix, second degree is body of the uterus, protrudes to the cervix into the vagina, and third degree, prolapse of inverted uterus outside the vulva. Next slide, please. So in acute, we see that it occurs within 24 hours of delivery, whereas in subacute and chronic, it happens later. Beyond 4 weeks, it is chronic. Next one. Causes. excessive contraction. Whenever you try to pull on the cord, try to separate the placenta in an unseparated placenta, excessive giving fundal pressure, especially when the uterus is relaxed. Placenta accreta or partially accreta, if you try and pull out the placenta, you may have a uterine inversion in your hand. Congenital some women are predisposed to inversion, fundal implantation of placenta, and some iatrogenic causes. Next one. So mismanagement of third stage, always remember, do not pull the cord when the uterus is atonic, and also do not give fundal pressure, undue fundal pressure when the uterus is atonic. Do not try Creed's expression while the uterus is relaxed. And also faulty techniques in MROP. And also while separating the retained placenta, a portion may remain attached and the fundus is also withdrawn along with it. Next slide, please. So what are the symptoms, or what happens when there is an inversion? Invariably, there will be hemorrhage and there will be severe abdominal pain in the third stage. Patient will suddenly go in for hypotension and bradycardia. And we see that this shock is out of proportion to the blood loss, usually just because it is a neurogenic shock. The uterus fundus is not palpable abdominally, and we may find a mass in the vagina on vaginal examination. Sudden cardiovascular collapse, then abdominal tenderness and absence of uterine fundus should make us suspect a uterine inversion. Any patient suddenly going into shock, you have to think about inversion. Next slide, please. So this is the management. Actually, a code blue, or actually in our case, in an obstetric collapse, we have a code pink. Immediately resuscitate the patient, have an IV access, give fluids and bolus replacement of fluid. Try to immediately replace the uterus as early as possible. That itself may deal with the problem. If the uterus is replaced, you can then do not remove the placenta and then replace. Replace the uterus and only then remove the placenta and start her on oxytocin. Give her oxytocic agent to contract the uterus and give antibiotics. If the uterus cannot be replaced, go for a GA. And there are two methods, either a manual reduction called Johnson's method or an O'Sullivan's method. Next slide, please. So it's all about teamwork. Again, every emergency, teamwork. Resuscitation and uterine repositioning simultaneously should happen. A team should act immediately. And this is where the postpartum hemorrhage drill helps you a lot. And the quickest way to treat the neurogenic shock is to replace the uterus. Next slide, please. So this is how we manually reposition. This is called the Johnson's method. The principle behind this, the part which is inverted last is replaced first. So whichever has come out last, you try to reposition it first, and then the first, whichever part has come out first, you replace it. Next, please. Next slide, please. O'Sullivan. Next is O'Sullivan's hydrostatic method. Here what happens is we pass a tube into the posterior fornix. We depend on the hydrostatic method pressure to revert the uterus back to normal. A tube is passed into the posterior fornix. We close the vulva and warm saline is run until the pressure gradually restores the position of the uterus. Alternatively, vacuum cup, the elastic cup can be used to close the vagina, create a vacuum there, and then introduce the fluid through the vacuum, the elastic cup, and then again, the principle behind it is the same. Next slide, please. So if it is failed, you can go for surgery. There are many surgeries, Holstein surgery, Spinalis method, Kushner's method, or in some are vaginal procedures. Even we may have to go for hysterectomy in intractable cases. Or you can open and also use a vacuum cup to restore the anatomy of the fundus of the uterus. Next slide, please. So these are my take-home points. Third stage complications, be aware of it because they are life-threatening. Be ready for it anytime. Active management of third stage of labor saves lives. So be thorough. All labor ward healthcare workers should be thorough with active management of third stage of labor. Then retained placenta accreta syndrome often needs multidisciplinary team management. Anticipate it, aware of it, Always rule out placenta accreta in the previous cesarean and previous cases. Anticipate, prepare, and plan. Plan for obstetric hysterectomy. Discuss with the patient. Arrange blood. Involve the urologist. Involve the anesthetist early on. And vascular clamps may be a practical solution, as we have seen in Kerala. Prevent uterine inversion. Inversion is also most often happens due to mismanaged third stage. And always the labor room staff should be drills ready, because any of the PPH drill, shoulder dystocia drill, inversion drills, we should be ready with the drills, and we should be always ready to tackle the complications. Thank you. So if there is time, I can show you the clamp, vascular clamp. This is just for your academic interest.
Yeah, sure, ma'am.
Yes. Can you just, is it visible? So this is the clamp.
Yeah, it's visible.
Okay, so this is a clamp. As you can see, there is a gap in between. There is a gap. So this gap ensures that there is no injury. So far, we have followed up the cases, no injury, no vascular aneurysms reported after the procedures. Okay. Initially, our anesthetists were very worried, but now they also support, because the blood transfusion requirement has come down drastically. Okay. Once again, I thank Dr. Bengal for having given me this opportunity. I think, Bengal sir, do we have the questions later, or?
Yeah, we'll have the questions at the end, ma'am.
Okay, thank you. Okay.
Yeah, thank you so much. So after this, now I think Dr. Shuchi has joined again, and I would like to invite her for a session on non-clinical components of PPH bundle.
Yeah, so I will do my share screen. I've already been introduced, so we can start off with the presentation.
Sure.
Okay, so having discussed the clinical aspect, and I must thank all of you for bearing us for the last 4 hours, and maybe you have to bear us for another 1 now. We move on to the lighter part, which is the non-clinical components of PPH bundle. So this in fact completes the PPH bundle, which has been advocated by Division of Global Health Innovation, Massachusetts General Hospital. And these slides are the product of their hard work, and they have the copyright for it. So as you have seen earlier, that PPH emergency response was the clinical part, and the non-clinical part, we have facility readiness, network integration, teamwork and communication, which have to go hand in hand, and which has, in all these aspects, respectful maternity care has to be there. And in addition to it, we require a very good data monitoring and quality improvement with leadership. So Dr. Poonam had introduced these concepts, and now I'll go into a slightly more detailed aspect of each of them. So the most in thing now is respectful maternity care in a PPH emergency. You can see these ladies who have had a traumatic experience of birth, but they are being given respectful maternity care. The babies are with them, they're allowed to feed their baby. So quality of care is not only the provision of care, but it is also the experience of care. So even after going through the traumatic experience of a PPH, a mother will consider it to be a pleasant experience if we have given her a respectful maternity care. So this emphasizes the centrality of respectful maternity care in emergencies by noting that consideration, respect, and compassion for every woman and newborn child should be the foundation of all maternity care, even in the event of complications. So we should make sure that we are maintaining her freedom from harm and ill treatment. We are taking an informed and giving her information and taking an informed consent from the patient and relatives even during emergencies. We are maintaining her privacy and confidentiality, even though we are dealing with the problems such as PPH, where we may have to expose her, but we still have to maintain her privacy. We have to treat her and her relatives with dignity and respect, equality and non-discrimination on basis of caste or anything else. Every woman has a right to health care and autonomy should be preserved. So it is a thinking thought for all of you now. So what are the challenges in the present Indian scenario in providing respectful maternity care in a PPH emergency? How can we get better at providing respectful maternity care? So this is a thinking process which should start, and you should introduce respectful maternity care at your facility. So it encompasses respect for women's basic human rights, their autonomy, dignity, feelings, choices, and preferences should always be respected. Then I showed you the earlier slide. In between, there was teamwork and communication, right? So teamwork and communication, facility readiness, and network integration all go together along with PPH emergency clinical care. You can see this football team and you can see this team. So what is the difference? This is an international team which is more organized, whereas this is a team which is playing in the normal surroundings, and probably they are not so organized as the team which I showed you earlier. So a good emergency team will respond rapidly, communicate, coordinate, and cooperate with each other, make the right diagnosis, use great clinical skills, no delays and no errors. So though we had a casualty in between during our presentation, because of our good teamwork, we could manage it and you didn't have any pauses. So similarly, when you're managing a patient of PPH, you have to maintain this team dynamic so that every team member is contributing and is respected. There are various models which have been advocated, which is the shared mental model, situational awareness, communication tools, continual learning and improvement. But at the end of it, keep the goal in the mind, which is to save the mother who is having PPH. As talked about earlier, the emergency response team has an in charge, assistant, a supplier, an informer, and all of them work together when they are faced with the emergency. This is a PPH emergency care checklist which you are supposed to use, which involves the primary response and the refractory PPH management. At the end of your management, you should have a simulation debrief as to how did you feel, was the response efficient, how effective was the response, what went well, and what could we do better. So these debriefing sessions are very important. You can see how a professional team is much better in achieving its aims. These are the communication tools which we have talked about. First is debriefing. Second is situation, background, analysis, then assessment of the situation, and then recommendation for further emergency management. Third is a closed loop communication between members of the team as to how they could have worked better. This is the huddle method where all the team members have got together, discussed and decided what is best. This is a board method where at the end of handover, you give an idea as to which patient is having what problem and which patient needs attention. It is put on the board. So this is how teamwork and communication can be maintained. The third part of it is leadership. So as discussed earlier, leadership is not a position or a title. It is an action and example which is set by the leader. A leader is one who knows the way, goes the way, and shows the way. He takes people where they want to go. A great leader takes people where they don't necessarily want to go, but ought to be. So this is how a good leader can take people and reach heights. So the roadblocks which are there on reaching the peak of this summit can be removed by an expert leader. So elements of successful change management are relative advantage of the proposed change, simplicity of the change and transition, ability to observe the change and celebrate the success. Some are early adopters and some are late. The third part of it is facility readiness. So all, as discussed earlier, they all go hand in hand. So if you have a great team, but your facility is not ready to accept a patient of PPH, then there is no point in having a great team. So you should have facility readiness in the form of services and skilled health workers, adequate infrastructure, emergency response team, adequate drugs, supplies and equipment available. And what are some of these barriers to effective facility readiness? It could be lack of staff participation, accountability, inadequate infrastructure and staffing. So whenever you're having a facility where you're managing PPH patients, you have to make sure that infrastructure, human resources, leadership, funding, skills, everything is there. So you need to have facility readiness to add a perfect team and a perfect leadership. So how do you achieve this readiness? So this is the PPH emergency response commodities checklist, which should be available with you every time. You don't have to search for each item when a patient is coming to you with PPH. So 24/7 availability of essential drugs, services, emergency response team. The providers must maintain skill and staff participation and accountability should be there. The facility readiness toolkits should be available with you. This is not how your institute should set up the emergency response areas. They should be much cleaner and better like this. And this is the checklist for setting up emergency response areas, which can make your facility ready to receive any emergency. Another part of this non-clinical component is network integration. Now, network integration is the integration between a lower facility and a higher facility, and it is bidirectional. So the higher facility also communicates with the lower facility regarding the patient. So we work as one team, there's bidirectional communication, and there is improvement in the way the patients are referred to us and how we give them a feedback. So we establish contact with the lower health facilities and then plan and implement the activities which involve team building, training, talking, transferring, tracking, and thanking them at the end of the whole procedure once the patient is managed. This is an example of a WhatsApp group. So as soon as the patient is shifted from a lower facility, they give us all details of the patient, and then we, once we know like what is her condition, we treat her. And once we're about to discharge her, after 3 days, we show them what has happened to the patient, what we have done, and how and when we are going to send her back. So this integration is to be there between the lower and the higher facility. These are the checklists which need to be taken care of in the and you have to make sure that the communication, assessment, and everything has been done properly. The receiving facility is called up and told about the patient's condition so that they are ready to receive the patient and give immediate care. Now, the last but not the least important is improving the quality of PPH emergency care. And in this, I must thank NQSIN, Dr. Vikram Datta and his team, who had initiated this quality improvement program in our institute. And we have been all trained in the POCI methodology of quality improvement. So we don't have to reflect back, but we plan forward. So first of all, identify the problem, then you plan a change, try out the change, check if it is work, and then either you adopt that change or you can modify it and adapt it, or if it doesn't work, you can abandon it. So these are the plan, do, study, act cycles, which you have to carry out for each change which you had decided in your setup. You have to choose a QI team and then plan a change. And along with this, there is going to be a lot of collection of data. You have to measure and monitor what is the outcome of that change. But this is not to be made very cumbersome, otherwise people will not do it. So it has to be a part of your routine procedure, like whether oxytocin was given at the right time or not, whether massage was given or not, so that you know that how many patients it was not given timely and they had PPH. So we do a quality improvement cycle to see as to how we can improve it so that every patient receives the oxytocin, every patient receives the active and doesn't land in a problem. So this is how we work on it. So you have process measures, you have outcome measures, and you have balance measures. And this is how we collect the data. This is the process of improvement. So developing world-class emergency care takes time, and in 2017, the bundle approach came up. So the main takeaway points are it is a useful framework for improving the quality of emergency care. It is a systematic approach that includes identifying the problem, selecting and trying out a change, check to see if the change worked, adjust the change based on what was learned, repeat the process as needed, and accurate data is essential to quality improvement process. So that's all about the non-clinical components, and we now move on to the next talk. A big thanks to Dr. Vikram Datta and Dr. Bangal, who has worked day and night in organizing this seminar. I thank him personally for inviting me to be a part of this. Thank you, sir.
Thank you so much, ma'am. For the next session, I would like to invite Dr. Prabha Ranjan ma'am, who is consultant gynecologist at Bhagwan Mahavir Hospital, Pitampura, Delhi. Ma'am is national trainer for comprehensive abortion care, postpartum contraception, and medical legal examination of survivors of sexual assault. Ma'am is also a governing board member with NQCN and a member of National Mentoring Group for Lakshya. Her special area of interest include high-risk pregnancy, minimal invasive surgery, and quality improvement initiatives for mother and child care. So I invite you, ma'am, to speak about sudden postpartum collapse and amniotic fluid embolism, recognition and management.
Thank you, Ashna, for the introduction. And okay, I'm sharing my screen.
Sure, ma'am.
Okay. So my screen is visible?
Yeah, it's visible now.
Thank you. So thank you, Ashna, for the introduction, and thank you, team NQCN and Dr. Bangal sir, for giving me this opportunity to be a part of this excellent online online obstetric skill building workshop. So we have come to the last session of today's workshop, and in next 15 to 20 minutes, I am going to discuss about sudden postpartum collapse and amniotic fluid embolism, its recognition and management. So, sudden postpartum collapse is defined as an acute event involving the cardiorespiratory system and or brain, resulting in a reduced or absent conscious level and potentially death at any point during labor and up to 6 weeks postpartum. As collapse is not a reported event, the true incidence is difficult to estimate, but it could be as high as 6 per 1,000 births. And causes of sudden postpartum collapse can be remembered easily by following the mnemonic 4H, 4T, and E. The 4H includes hypovolemia, hypoxia, hypo or hyperkalemia, and hypothermia. The causes of hypovolemia are hemorrhage, acute uterine inversion, septic or neurogenic shock, and sometimes high spinal block. And the causes of hypoxia are mainly cardiac causes like myocardial infarction, aortic dissection, peripartum cardiomyopathy, cardiac arrhythmias, airway obstruction secondary to aspiration or foreign body. 4 T's include thromboembolism, toxicity, tension pneumothorax, and cardiac tamponade. Thromboembolic events are usually due to amniotic fluid embolism, pulmonary embolism, air embolism, myocardial infarction, or cerebral vein thrombosis. In obstetric setting, two common drugs giving rise to drug toxicity are magnesium sulfate and local anesthetic agents. The E of 4H14E is eclampsia and preeclampsia. And acute pulmonary edema and intracranial hemorrhage are the most common causes of sudden postpartum collapse in cases of eclampsia. Other causes of maternal collapse are vasovagal attack, hypoglycemia, metabolic electrolyte disturbances, epilepsy, intracranial hemorrhage, and anaphylaxis. Intracranial hemorrhage, the causes are mainly uncontrolled hypertension, particularly the systolic hypertension, ruptured aneurysm, and arteriovenous malformation. Sudden postpartum collapse is an unpredictable, dramatic, life-threatening event which may occur in the absence of any significant risk factor. However, some of the risk factors or predisposing risk factors are like severe anemia, severe hypertensive disorders of pregnancy, coagulation abnormalities, sepsis, prolonged labor, previous cesarean section, morbid adherent placenta, poor socioeconomic status of the patient, and pre-existing medical or surgical disorder with pregnancy like chronic hypertension, diabetes mellitus, cardiac disease, epilepsy, chronic liver or renal diseases, etc. So management of sudden postpartum collapse follows the standard A, B, C, D approach to resuscitation of an adult, which includes management of airway, breathing, circulation, disability or neurological status of the patient, and exposure and environmental control, which includes adequate exposure of the patient for full assessment, avoiding potential hypothermia. So resuscitation should start immediately and effectively for better maternal survival. Maternal survival also depends on the etiology of maternal collapse, facilities available at the place of maternal collapse, and the training and expertise of those on the spot at the time of collapse. Fetal survival depends primarily on effective maternal resuscitation. However, many organs undergo significant physiological and anatomical changes during pregnancy, and these changes can hamper effective resuscitation during a maternal collapse. Weight gain in pregnancy and breast enlargement and laryngeal edema can all contribute to difficult intubation. There is increased risk of aspiration during pregnancy due to reduced esophageal tone secondary to the progesterone effect, delayed gastric emptying, and raised intra-abdominal pressure secondary to the gravid uterus. 20 weeks onwards, the gravid uterus causes compression over aorta and inferior vena cava. Aortocaval compression significantly reduces venous return and cardiac output by up to 30 to 40%, causing supine hypotension. Gravid uterus significantly reduces the efficacy of chest compression during resuscitation. A pregnant uterus at term receives almost 10% of the cardiac output. So a large volume of blood can be lost rapidly in case of hemorrhage, leading to hypovolemia and shock. Dilutional anemia, changes in lung function, diaphragmatic splinting, and increased oxygen consumption from the uteroplacental unit make the pregnant woman more prone to rapid development of hypoxia and make the ventilation more difficult. So make necessary adaptations to the management of collapsed pregnant women according to the physiological and anatomical changes of pregnancy and start resuscitation. Quickly assess whether the mother is awake or responding to verbal command or painful stimulus or is unconscious. Check whether she is breathing and is there a heartbeat. Then clear the airway by head tilt and chin lift and secure it by intubation with a cuffed endotracheal tube as early as possible. If CPR is not required, tilt the patient to 15 to 30 degree left lateral on a firm surface to relieve the aortocaval compression. And if CPR is required in that case, you have to do left uterine displacement of the uterus for effective CPR. And just lateral tilt of the patient by 15 to 30 degree actually hampers the effective chest compression while doing a CPR. So it is better to do left uterine displacement for an effect. Attempt diagnosis but proceed with basic life support and always check that the environment is safe. Manual left uterine displacement relieves aortocaval compression effectively in women above 20 weeks of gestation or where the uterus is palpable at or above the level of umbilicus. It permits effective chest compression in the supine position in the event of cardiac arrest. And it is performed using a two-hand pull technique in which by placing a hand below the uterus on the maternal right and pulling the uterus slightly upwards and to the left. If the mother is not breathing but a pulse is present, provide high flow 100% oxygen. Artificially ventilate with airway or bag and mask until intubation is achieved. If there is no carotid pulse, proceed immediately with CPR. In fact, if there is no breathing, we should not lose any time to check for pulse and we should immediately start doing CPR. So 30 compressions should be given over the center of the chest, the direction being perpendicular perpendicular to the chest wall, and there should be at least 4 to 5 centimeter of chest movement. Movement of less than 4 centimeter may cause ineffective CPR, and if the chest movement is more than 6 centimeter, it may cause fracture of the ribs. Give 2 breaths after 30 chest compression to maintain a 30:2 rhythm until the patient is intubated. Allow adequate recoil in between the chest compressions. Avoid CPR fatigue and change the person every 2 cycles if possible. The person doing airway management and the person who is doing manual uterine displacement and the person doing CPR can rotate among themselves to avoid CPR fatigue. Interrupt chest compression only to assess rhythm and check rhythm every 2 minutes. When the patient is intubated, 100 compressions per minute and 10 breaths per minute can be given. Get an ECG connected as soon as possible to see whether the patient is in arrhythmia or asystole. The treatment for ventricular arrhythmia is external defibrillation. And if defibrillation is required, the same setting should be used as in the non-pregnant patient, as there is no change in the thoracic impedance. And shocks from a direct current defibrillator have no adverse effect on the fetus. Repeat DC shock if necessary. Automated external defibrillator is useful where people may not have rhythm recognition skills. The treatment for asystole is IV adrenaline 1 milligram. Repeat adrenaline injection every 5 minutes if necessary. Establish IV line by inserting 2 whiteboard cannula as soon as possible. And correct reversible causes of maternal collapse like hypoxia, hypovolemia, hypo or hyperkalemia, and hypothermia. Empty the uterus by conducting a perimortem cesarean section if no response to if there is no response to correctly perform CPR after 4 minutes. The aim of perimortem cesarean section, better known as resuscitative hysterectomy or emergency uterine evacuation, is to facilitate maternal resuscitation and not to save a baby. It is to be done even if the baby is dead and should be done on the spot within 5 minutes of the collapse. The rationale for this time scale is that the pregnant woman becomes hypoxic more quickly than the non-pregnant woman, and irreversible brain damage can ensue within 4 to 6 minutes. Delivery of the fetus and placenta reduces oxygen consumption, improves venous return and cardiac output, facilitates chest compression and makes ventilation easier. It can also facilitate direct cardiac compression through the diaphragm against the posterior aspect of the anterior chest wall. So we should not waste time on moving the patient and should perform perimortem cesarean section on the spot. And for performing a perimortem cesarean section, no anesthesia is required. Only a scalpel and 2 clamps for the cord is required. Incise the abdomen and uterus in any way which facilitates the most rapid access. If someone is unfamiliar with a midline abdominal incision and a classical uterine incision, delivery can be achieved rapidly with a transverse approach also. The operator should use the approach they are most comfortable with. If the mother responds to resuscitation, then transfer the patient or the mother to theater for anesthesia and hemostasis. The doctrine of to the best interest of the patient would apply to conduct of this procedure being carried out without consent. If patient survives the initial resuscitation, management of a specific cause of maternal collapse should commence. Patients should be transferred to a high dependency or critical care area with appropriate staff and monitoring facilities. A multidisciplinary team approach is required, including an obstetrician, anesthetist, hematologist, intensivist, and a microbiologist. In the community setting like PSC, CST, or district hospital, basic life support should be administered and rapid transfer to a tertiary care center should be arranged. Now coming to the amniotic fluid embolism. Amniotic fluid embolism is a life-threatening obstetric emergency presenting as collapse during labor or delivery or within 30 minutes of delivery in the form of acute hypertension, respiratory distress, and acute hypoxia. It occurs in 2 to 8% per lakh deliveries and is responsible for between 7.5 to 10% of the maternal mortality. The pathophysiology of amniotic fluid embolism is incompletely understood and has been compared to anaphylaxis or severe sepsis. It may be due to complement activation and activation of coagulation pathway. The diagnosis in non-fatal cases is essentially clinical and of exclusion based on the clinical presentation. There is no established accurate diagnostic test pre-mortem. Amniotic fluid embolism is considered as an unpredictable and unpreventable event without an unknown cause. However, there are some risk factors like multiparity, advanced maternal age, trauma, induction of labor, polyhydramnios, placental abruption, placenta previa, eclampsia, cesarean section or operative vaginal delivery, cervical laceration, and or uterine rupture. The classic triad of AFE is hypoxia, hypotension, and coagulopathy. The typical history is that a woman in the late stage of labor or in immediate postpartum period becomes acutely dyspneic with hypotension. There may be a preceding period of agitation, confusion, or a sense of impending doom. She may experience seizures quickly, followed by cardiac arrest. If undelivered, the fetus will demonstrate loss of heart rate variability, followed by decelerations, and ultimately a terminal bradycardia. Coagulopathy often develops if the mother survives, giving rise to massive postpartum hemorrhage, leading to death of the patient. The prognosis the AFE is associated with high rate of morbidity and mortality. Maternal mortality approaches as high as 80%. 50% of the women die within the first hour of onset of symptoms. Maternal survival improves with early recognition and prompt resuscitation. Neonatal survival rate is around 70%, and neurological status of the infant is directly related to the time elapsed between maternal arrest and delivery. The risk of recurrence of AFE is unknown. However, successful subsequent pregnancies have been reported. There are no laboratory tests to either confirm or refute the diagnosis of AFE. Laboratory values are useful in providing supporting measures for the patient. Arterial blood gas analysis, the changes are consistent with hypoxia or hypoxemia. There may be prolonged prothrombin time, fibrinogen level may be reduced. On chest radiograph, evidence of pulmonary edema may be observed. ECG may show tachycardia, ST segment, and T-wave changes consistent with right ventricular strain. On autopsy, blood vessels in the lungs may show evidence of fetal debris like squamous cells, vernix, mucin, and confirm the diagnosis of AFE post-mortem. The treatment of AFE is supportive and includes the following. Steps must be taken to stabilize the patient as soon as symptom manifests. Call for help and involve multidisciplinary team. Follow ABCDE approach of resuscitation. Perform perimortem cesarean section after 4 minutes of ineffective CPR if patient is not delivered or uterus is palpable at the level or above the level of umbilicus. Perform perimortem cesarean section after 4 minutes of ineffective CPR if the patient is not yet delivered. And do manual uterine displacement if the uterus is palpable at or level of the umbilicus. Treat hypotension with crystallite, blood and blood products at the same time. And we should not wait for the results of coagulation profile to come. And giving crystallite first and then blood and waiting for blood products may hasten the development of coagulopathy by dilating the clotting factors more fast. And the blood loss and the ratio of giving crystallite is in the ratio of 1:3. If for 1 liter of blood loss, we should give 3 liters of crystallite to maintain a 1:3 ratio of blood loss and crystallite. And PRBC, FEP, and platelets should be given in the ratio of 1:1:1. And we should not delay giving blood products for the resuscitation of the patient. Use uterotonics and tranexamic acid to limit postpartum bleeding. Perform bilateral uterine artery embolization to control the hemorrhage if facility available. Consider steroids as the process may be immune mediated. Consult the ICU in advance or transfer to a tertiary care hospital once the patient is stable. Consult neurologist if a patient shows sign of neurological deficit. So to improve outcomes after maternal collapse, be ready with training. Life support training of all frontline staff reduces morbidity and mortality. Training courses should make mention of the adaptation of CPR in the pregnant woman. Have emergency equipment assembled and quarantined for emergency use. And we should keep a defibrillator machine, ECG machine, and pulse oximeter should be must in the labor room. Most of the labor room, as per my knowledge, there is no defibrillator, and ECG machine are also lacking in the labor room. So it is a good idea to have a own ECG machine and a defibrillator in labor room. Have system that assembles more staff quickly, and practice drills for active and effective resuscitation. Review, establish an obstetric early warning system to identify the patient at risk. Review and revise the whole event after each event and after each near miss. Documentation and debriefing. Accurate documentation in all cases of maternal collapse, whether or not successfully resuscitated, is essential. And poor documentation can have potential medico-legal consequences. Debriefing is very important, and it should be done by a competent professional for the woman, her family, and the staff involved in the event. So the take-home messages are: one of the biggest challenges with sudden postpartum collapse is its unpredictability and the need for constant vigilance. A logical structured approach using ABCDE should be used in and management of a collapsed patient. CPR should be modified by securing the airway as early as possible and displacing the uterus manually. Perimortem cesarean section should be undertaken after 4 minutes of unsuccessful CPR. Obstetricians should lead a multidisciplinary team in the management of critically ill pregnant women. And all staff should have drills and updates on obstetric emergencies and resuscitation. Thank you. Thank you for the patient hearing.
Thanks a lot, ma'am. With that, if we move on to that was the last session of the workshop. And now we move on to the question and answers round. I would like to invite all the faculty members, all the resource persons present here to answer these questions. So what we've done is we've tried to categorize these questions based on the sessions as they were conducted. So the first question is for Dr. Archana Verma, ma'am, by Shivani Rawat. So Ms. Shivani is asking, in which cases do we not do delayed cord clamping? Dr. Archana, ma'am, are you there?
I'm there.
Yeah, so there's a question for you, ma'am. In which cases do we not do delayed cord clamping?
What?
In which cases do we not do delayed cord clamping?
Basically, in HIV cases, we prefer early clamping.
Okay.
Also, in cases of extremely premature baby and in cases of RS negative pregnancy, and we do early cord clamping.
Plus, maybe babies who are asphyxiated, those who are not cried, where we want baby to be taken immediately to newborn corner. So those babies, we don't wait for pulsations to disappear, because we want them to be with the pediatrician for subsequent interventions early. So those babies also, we don't wait for delayed cord clamping.
The next question for Archana ma'am is, what are the causes of hematoma?
तो इतने तो डिटेल में बताया था hematoma. Whenever you are doing any internal maneuver, or especially obstructed labor, forceps delivery, venous delivery, or sometimes all the very high PIH also, and when there is a sudden rupture of this and varicose veins, and majority are like that only, and breech extraction or something dysplasia also.
And sometimes if the baby is too big, spontaneously also there can be vaginal wall hematoma. So if the baby is too big and there is a delayed second stage, there can, because of the excessive.
Yes, was that obstructed labor because of any cause and dysplasia.
Yeah.
Okay. Another question by Sister Chalapathy for again Dr. Archana ma'am. What measures are developed countries taking to avoid previous scars on uterus?
Developed countries are actually what they are doing. They are doing the avoiding the first scar is very, very important, and then if especially because the things are very much different there, there's so much of good antenatal care and intrapartum fetal monitoring, and they can manage even the preterm babies also. And so even according to them, they plan for the vaginal birth even in the previous 2 cesareans also.
Okay. Thank you, ma'am. The next question is for Bengal, sir. Ms. Promila Malik wants you to comment about use of metallic suction cannula for controlling PPH.
Yes, metallic suction cannula, which I have not used, of course, for this purpose. But there is Paniker's cannula, which is being used, and people are saying that it is quite effective in controlling PPH through suctioning of the uterine cavity and creating negative pressure. But I do not have any personal experience about this cannula, but the reports are quite encouraging. I have gone through the video by Dr. Paniker in his Paniker suction cannula. They have shown very promising results, and even some of my colleagues are using it. And I am also planning to purchase it, but I do not have at present personal opinion and experience about Paniker's cannula or any suction cannula for use in PPH. If anyone has the experience, then can share.
For that they can do they can go and check the YouTube of and there's lot of then the videos sent by Dr. Paniker and Dr. Samarthan especially.
Okay, thank you so much. The next question is for Dr. Shuchi ma'am by Khushbu Saha. So she wants to ask, for how long do we provide the bimanual compression in one go?
Is Dr. Suchi there?
I don't see her here.
Okay, so maybe I will start answering. Suchi can join afterwards. Bimanual compression is an emergency procedure to immediate control bleeding, sort of a first aid, till we arrange for subsequent other procedures, or maybe surgical intervention, or maybe UBT or NSG. So it's an immediate measure, and there is no hard and fast time limit for how much time we can do bimanual compression. It can be done for whatever amount of time, and there is no as such limit to use our bimanual compression as a method for controlling postpartum hemorrhage.
Sir, if I may just add another line to you, very nicely explained, sir. I just wanted to re-emphasize that bimanual compression by itself in most cases will not be able to stop postpartum hemorrhage. In most instances, as you remove your hand, if other drugs have not come into effect, the bleeding can start again, and you have to be prepared to take further action if you see active bleeding present. Thank you.
Thank you, ma'am. We have some questions for Poonam, ma'am. Do we have Dr. Poonam here with us?
Ashna, please
Okay,
go ahead
so
with
I
the
think we
question.
can open it for the panel itself.
Yeah, yeah.
So one question from Sonu Yadav. He wants to ask, shouldn't the air be removed from the condom before inserting it into the uterus?
That is obviously a little bit, because it was a bottle, so it was creating problem, I think. But when after the delivery, the os is so much open, there won't be any problem.
Okay.
Because you are doing either pre-prepared. If you have kept the pre-prepared one, then there may be a chances of infection and all here, because within minutes you are tying there over there only, and so a little bit of air is not going to create any problem.
And squeezing the condom is one of the step of making a UBT. So we first squeeze the condom in the tip, and then we put it on the catheter. And so, Dr. Bangal sir, I want to add some other modification to this simple UBT that is called Chhattisgarh balloon. And in this, we can also measure the concealed hemorrhage occurring inside the uterus, because this UBT is a blind process. We cannot measure what amount of bleeding is still going inside the uterus. And by simple modification to this, by using a simple Follis catheter, and by simply cutting the tip, by adding more 2 or 3 steps, it also helps in keeping record of what amount of bleeding is going inside the uterus.
Yeah, yeah.
We can have that video later on in any subsequent.
Yes.
I have been seen this CG balloon.
CG balloon.
Yeah, it is
Yes. That can be used. There are so many modifications.
Yes, sir.
Of course, if we use Bakri balloon, and if it is possible, definitely there is a separate provision for whatever
Yes,
blood
it
gets
is like Bakri adaptation of Bakri balloon
nowadays a
itself.
new, Dr. Bangal sir, nowadays I just somebody met me, and there is a new already everything is filled with it is attached to that bottle.
Yes, that is from South Africa. Name I just forgot. Maybe Preeti may be remembering it. It's just.
I was liking it it was looking very convenient, and even not expensive also. So
it's a single, just connect, and with the gravity.
Just connect and
and if the pressure, if the uterus starts contracting, the fluid again returns back to the bag.
Yes, and no need of this tying back, condoms and all, and definitely it is ready-made thing and very convenient.
Madam, that is Elavi balloon. ELAVI.
Yeah.
Elavi balloon from South Africa. Yeah.
I think very soon we can have the demo of that also. Dr. Poonam will be doing.
I do have that balloon also for demo purpose. Elavi. Okay.
That seems very promising and wonderful.
There is a study, if I may add, regarding that balloon, which is being done by Path India. It's already being studied.
So now we can leave, sir. Everything done.
Yeah, let's ask Ashna. Ashna,
Yeah,
there are any other questions?
Yeah, there are some more questions, sir.
Please go ahead.
Yeah, so Nilja Sood is asking, women in various communities cannot take decisions about their health and health-seeking places, etc. Even many women do not have the power to take decision to continue pregnancy. Then how to ensure respectful maternity care in Indian hospitals and health centers and homes?
Yeah. Maybe Poonam should have been there, but I can just say that respectful maternity care, we have realized that yes, it is a must and it should be implemented in all healthcare facilities. But of course, there are many factors which are associated with disrespectful maternity care, and those factors must be looked into when women, basically women, the gender bias, their literacy status, their empowerment, all factors are responsible. All factors do carry weightage when we think of giving respectful maternity care. Women who are literate, educated, know their power, know their know their rights, then definitely they will say that they will assess whether the maternity care is respectful or not. But those illiterate rural women, unaware about what situation, they just accept whatever. So it's a process. Process has begun in India, maybe in all developing countries. It will take time. As the literacy will go up, the expectations of the women will also go up. People will also realize that yes, respectful maternity care is a right of woman, and it is not some extra this thing given to the women. It is their right and it has to be provided. And there are even slowly the legal provisions will also come. If there is a disrespectful care, person will be punished and should be punished.
Yes. Okay, so I think we can take the last question now. Again by Neerja Sood. She's asking, teamwork is a challenge unless all health professionals respect each other. So are responsibilities and accountability an issue?
Yes, any healthcare setting, there is a team, healthcare workers. Team includes all, mainly the medical professionals, nursing staff, paramedical staff, maybe those who are working as AYA, everything. But the team leader should have all those qualities of a team leader. And if he has those qualities of a team leader, I think he will be able to manage the team and show the performance. So team leader is extremely important in a team for its performance. So of course, when it comes to the what you said, the last thing was the
responsibilities and accountabilities.
Yeah, responsibility at every level, at every person must be responsible and accountable for his or her job. Then if everyone is performing as per the expectations, the performance will definitely go up. But of course, yes, hierarchy has to be maintained, and team leader should have those additional qualities to manage the team. Anyone can add to what I said?
Sir, if I may just add a few lines here. The responsibility, the accountability has to come from all members of the team. And it is very important that the leader not only leads by example, but also makes the team come together as a team when care is being provided to the woman. And for that, it is very essential that as the team is performing their drills, this part is also emphasized that respectful care has to be provided to each woman. Each person has to act according to the rules. Accountability will be seen after the event of any catastrophic event, as the team sits down to debrief and see what went right and wrong, typically without placing blame. But yes, definitely accountability up to some level should be present in all members of the team. Thank you.
Sure.
Okay. Thank you so much. So that ends the question and answer session. And now we move on to the post-test questionnaire. The link for the post-test has been posted in the chat box. Kindly click on the link and answer the 15 questions. You have 10 minutes to answer these. Once you answer all the questions, you can click on submit. And please ensure that you enter your correct email ID so as to receive the link for the certificate. For all those who are joining us on YouTube, the link for the post test is in the description box.
Ashna, is it not that after the questionnaire, and if they give their link, then only they will get the certificate? Is it right?
Yes, sir. After they submit the questionnaire, they'll get a link for the certificate in the subsequent week from Monday onwards.
Yeah.
And they can fill in the feedback and receive the certificate after that.
Okay. Thank you.
You all have another 5 minutes to submit your responses. Okay, so in the meanwhile, I would like to invite Dr. Sushil Srivastav, sir. Sir is Associate Professor at Department of Pediatrics, University College of Medical Sciences and GTB Hospital, Delhi. Sir is Secretary at Nationwide Quality of Care Network, a national trainer for IMNCI, FPNC, ENCC, and Developmentally Supportive Care, NEST, POCI, and Neonatal Advanced Life Support. Sir, I would request you to kindly present the vote of thanks and give concluding remarks to this session.
Thank you, Dr. Ashna, for introducing me. And let me say that I was there for quite some time in the workshop, and it was very impressive. I'm really thankful for the esteemed faculty of obstetrics and gynecology, which were there today. They have devoted more than 4 to 6 hours for this beautiful session, which we had today. And I could see the response. I think we had at time about 360 participants logged in to this wonderful interactive workshop, and especially the skills sessions were pretty impressive. In fact, I was impressed by the technology and this platform by which our experienced faculty could demonstrate some critical life-saving skills which are required in delivery points. So it gives me immense pleasure on this day to thank our esteemed faculty for conducting this workshop. I am especially thankful to Dr. Archana Verma, Vice President, Foxy North Zone. I'm also thankful to Dr. Poonam Shivkumar, again a great champion of quality improvement and a member of Nationwide Quality of Care Network. She's head of the department, Professor OBGY at MGIMS Wardha. I'm also thankful to Dr. Anupa Khanna Vig, who is a consultant at OBGY at Piramal Swasth Kendra in New Delhi. I'm also thankful to Dr. Shuchi Jain, again from MGIMS Wardha, professor in OBGY, again a quality improvement enthusiast. Dr. Anuja Bhale Rao, professor in Department of OBGY and KP Salve Medical College, Nagpur, Maharashtra. I'm also thankful to Dr. Reshmi CR, additional professor, Department of OBGY, Government Medical College, Thrissur, Kerala. Dr. P.T. Priyadarshini, Assistant Professor, Department OBGY, AIMS, Gorakhpur, UP. Dr. Prabha Ranjan, Consultant Obstetrician Gynecology, Bhagwan Mahavir Hospital, New Delhi. I'm especially thankful, and I think it goes beyond saying thanks to Dr. Vidyadhar Bengal, who is a great champion of promoting life-saving skills in delivery areas at remotest part of our country. He has been a great supporter and a great pillar of strength for Nationwide Quality of Care Network in spreading your important obstetrics and gynae skills, not only to your gynae residents and doctors, but also to critical midwives and labor room nurses who are manning these posts. So Dr. Vidyadhar Bengal, it's really a pleasure to see this workshop coming as a success. And yes, of course, it is not because of effort of one or two, but of all your esteemed faculty, very nice selection of faculty from all across the country, and excellent deliberations. In fact, I was really impressed with the skill stations, and I'm pretty confident that many of my own students from my medical college were logged in and were being benefited by this wide variety of expert opinion and skill demonstration. So I think it has been a great experience for even at us at our place at Nationwide Quality of Care Network in terms of organizing such outreach platforms for a good sensitization and revision of important skills. With that, I will also like to thank Dr. Ashna Dhingra, Dr. Rahul Garde, and Rashi, who are also an important pillar of strength for organizing such a wonderfully successful event, which connected more than 300 doctors and benefited, I am pretty sure, benefited a lot many patients whom these doctors were going to attend and manage them. So it has been a great privilege on behalf of Nationwide Quality of Care Network and Nationwide Quality of Care Community of Practice that this theme of prevention and management of catastrophes in labor has been a remarkable success. I would be looking specifically for your feedbacks for all the participants, because ultimately it is for the participants for which we all have gathered together. And I'm pretty sure that the participants would have enjoyed the academic feast today. And please give your feedbacks and give your suggestions also, which would help us, Dr. Bangal, Dr. Anupa Veg, Dr. Prabha Ranjan's team, of organizing better and much more such events in future. With that few words, I wish to thank you all and have a good day and remain safe and take due precautions for the COVID. I will request if somebody wants to add, Dr. Bangal, if you want to add something, you please go ahead.
Thank you, Dr. Sushil, for your kind words. It was good to see lot many people joining this particular workshop. I thank all the faculty members for accepting our invitation to be part of this activity. And I think everybody is quite happy to be a part of this journey. And we will be arranging many more such workshops, considering the response which we received for this maternal health activity. And we'll continue to have similar activities in future too. Thank you, NQCN, for considering me to be part of NQCN and giving me opportunity to organize such event.
Sir, it's your organization. I would again reiterate, Dr. Anupa, Dr. Bangal, Dr. Prabha Ranjan, it's all yours. This is meant mainly to help all our friends and doctors who are working in trying circumstances, obstetricians, not the least. We can only imagine the amount of your challenges which they face, whether you are in medical college, whether you are in a district hospital. So, and I could see the dedication, the faculty, the young faculty, Dr. Preeti and all that, they were presenting very nicely. It was very impressive. And congratulations and kudos to you all. And we will be sending you the feedback, definitely, to all the faculty to plan your future sessions. Thank you very much.
Thank you, Dr. Srivastava.
Thank you so much, sir. With that, I think we can end the session now. Since we've got an overwhelming response, all the participants will be receiving their certificate links over the next week. So maybe by Friday, you can get the certificate.
Thank you, Rashi.
So we'll send you a link to the feedback. So kindly fill in the feedback and then you can get your.
Yeah, and if somebody misses your certificate, please don't feel bad. You just connect to our office. Dr. Ashna would be sharing you the email ID, and we will track it up and you will get all your certificates. Just because of the overwhelming response, please bear with us. We will be sending you the certificates and you will get it all. Thank you.
Thank you, everyone. Bye-bye.
Bye-bye, Rahul.
Yep. Bye, sir.
Bye.
Thank you very much.
Thank you so much, ma'am. Thank you.
Thank you, Dr. Ashna. Thank you. Thank you, team of NQCN. Srivastava sir, Vikram Datta sir. Okay.
Okay, ma'am. Bye. Good day.